Good morning, ladies and gentlemen, distinguished guests. Karibuni, welcome, to the 29th Tanzanian Surgical Association Annual General Meeting. I would like to welcome you and thank you for coming. And I hope everyone who has registered has already registered, and everybody who has registered online as well. May I take this position to welcome the Secretary, Boma.
Good morning, ladies and gentlemen. Dr. Usiri, RMO MOROGORO, on behalf of Permanent Secretary, Minister of Health, Dr. John Jingu, Dr. Amani Malima, the President of Tanzania Surgical Association, Dr. Olivia Kimario, President-elect, Tanzania Surgical Association, Dr. Laurian Rwanyuma, Honorable Treasurer, Tanzania Surgical Association. Ladies and gentlemen, good morning. On behalf of the Council of Tanzania Surgical Association, I would like to welcome you all to this conference, 29th Conference and Annual General Meeting for Tanzania Surgical Association, which is being held here at Morena Hotel in Morogoro. My job here is to introduce the President of Tanzania Surgical Association and to welcome him to welcome speech before welcoming the guest of honor.
Thank you, good morning all. Our guest of honor, as the TSA leaders were seated in front, our former presidents and senior members of the Transplant Surgical Association, surgeons, residents, surgery, registrars and all other medical professions who are in this room, and waandishi wa habari, thank you for covering everything. Good morning again. I'd like to take this opportunity to address my sincere thanks to our guest of honor. Kwa tulangu kwa Kiswahili, tuendelea kwa Kiswahili. Mheshimiwa mgeni rasmi, tupe nafasi hii kushukuru sana kwa kutenga muda kwenye ratiba yako ngumu. Najua pia hata ujio wako umekuja kwa kusindikizwa. Kwa hiyo tunakushukuru sana kwa kukubali kuja kufungulia kikao chetu hichi. Asante sana. Makofi jamani. Mheshimiwa mgeni rasmi, mkutano huu kama ilikuwa uchaguzi wa uchaguzi, lakini tumekuwa na hakijawahi kukumbwa na migogoro ya kiuongozi au mzozo na serikali. Hapa mbele yako kuna marais wastaafu waliokaa mbele. Napenda kumtambua Dr. Petronila Kiroe, Dr. Samuel Mungu, kuna Profesa Larry Akoko. Asante sana. Mheshimiwa mgeni rasmi, mkutano wetu kwa kawaida utanguliwa na kambi. Kambi hizo ni utamaduni ambao tumekuwa nao na utamaduni huu umekuwepo miaka yote. Kwa hiyo tunaangalia mikoa pale inayotuzunguka ya karibu na tunatoa huduma. Kwa mwaka huu, Mheshimiwa mgeni rasmi, tulipata nafasi hiyo ya kutoa huduma za upasuaji kwenye hospitali ya rufaa ya mkoa ya Iringa, lakini pia kwenye hospitali ya rufaa ya mkoa ya Morogoro. Lakini kama unavyojua mgeni rasmi, tulikuwa na kambi za madaktari bingwa wa Dr. Samia Suluhu Hassan, na kule pia kulikuwa na wataalamu wetu wa upasuaji kwenye kila halmashauri, kwa nao pia walishiriki. Aidha pia kwenye mkoa wa Pwani pia tulikuwa na watu wetu na mkoa wa Dar es Salaam. Kwa hiyo tumeweza kuhudumia watu wa kutosha. Mheshimiwa mgeni rasmi, hii imekuwa ikisaidia sana kupunguza gharama kwa wagonjwa wetu. Kama unavyojua, kwa kawaida wagonjwa hawa wakishakuwa wamejulikana wanahitaji huduma za kiupasuaji na hasa zile za kibobezi, wanalazimika kusafiri kutoka mikoa mbalimbali kwenda mpaka Dar es Salaam. Kwanza ni gharama za usafiri, pili tunajua ni gharama za malazi pale kwa kufikia, lakini tatu, hao wengine wanabidi wapate mpaka ruhusa kazini, au wengine wana shughuli zao binafsi zinabidi kusimama kwa muda. Kwa hiyo hili jambo tumelipunguza sana kupitia utaratibu wetu wa hizi huduma zilizotolewa. Kwa hiyo nitoe shukrani kubwa sana kwa madaktari wote walioshiriki kwenye hizi kambi, na wameshiriki kwa kujitolea, hawakuomba gharama zote. Nikawa ni utamaduni kwamba wao ndio sehemu yao ya kujitolea wanakuja kwa mwaka. Asanteni, asanteni sana sana. Mheshimiwa mgeni rasmi, upasuaji kwa kawaida huo hulenga maeneo fulani muhimu. Kwanza kabisa ni kuzuia vifo mapema, lakini la pili ni kurudisha utendaji kazi kwa viungo mbalimbali vya mwili, lakini na la tatu ni kujaribu kurefusha maisha. Kwa hiyo sasa, kupitia huo utaratibu tumekuwa tukifuata hivyo katika kutoa huduma zetu. Lakini kama unavyojua Mheshimiwa mgeni rasmi, bado tuna changamoto nyingi kwenye kutoa huduma. Sasa hivi tunashukuru, kwanza nianze kwanza kwa kutoa shukrani zetu za dhati. Kama unavyojua, kupitia pesa za uviko 19 hospitali zetu kuanzia za kanda, za mikoa na za taifa zimeongezewa uwezo mkubwa sana kwenye vitendea kazi, MRI, CT scan, ultrasound, vitu vya mitambo ya maabara, lakini na vitendea kazi mbalimbali. Isitoshe pia ile swala ambalo tulikuwa tunalijua ni changamoto huko nyuma, hospitali zetu nyingi zilikuwa hazina ICU. Sasa hivi ICU zimefika mpaka level hospitali za wilaya, lakini na EMD, Emergency Medical Department, nazo zimeenea. Kwa hizo huduma zimetusaidia sana, lakini bado tuna changamoto. Changamoto kubwa iliyoko ni gharama za huduma. Kwa bado tunaona kuna wananchi ambao wanashindwa kugharimia kumudu hizi huduma. Bado kuna ile changamoto ya kupitisha vigogo vya kusanya hela kwa ajili ya kulipia bili, au hata wengine kwenda kwenye vyombo vya habari kuomba msaada, wengine kushikiliwa mpaka hospitalini ili waweze kulipa gharama. Kwa hili nalo limekuwa tatizo. Kwa hiyo tulikuwa tunaomba nalo hili tuangalie jinsi ya kulifumbua. Lakini lingine, Mheshimiwa mgeni rasmi, kama unavyojua, wataalamu wetu hawa ndio wanaotoa huduma mbalimbali za kila daraja. Pale inapotokea, na wengi sisi tuko enroll kwenye bima ya afya ya taifa, changamoto kubwa tunayokutana nayo ni kuwa kuna baadhi ya huduma haziko kwenye bima. Tuna huduma za kubadilisha figo, kuna hizi za cochlea, kuna huduma za kubadilisha viungo, hip replacement, knee replacement pia, na vitu vingine vingi ambavyo haviko cover fully bima ya afya. Kwa hiyo ni kama yule mpishi ambaye unapika lakini huruhusiwi kuonja chakula. Sasa hiyo inakuwa ni changamoto kubwa sana. Kwa hiyo tulikuwa tunaliomba nalo hilo lifikiriwe, ili ingalau hata kwa sisi watu wa huduma na wale wanaowategemezi wetu waweze kufaidika na hizi huduma ambazo wenyewe tunazitoa. Mheshimiwa mgeni rasmi, lingine bado tunaona kuna changamoto bado ya udahili wa madaktari wetu kwenye vyuo, hata wale wanaotaka kuanza kozi za udaktari kupitia utaratibu wa GPA. Kwa hiyo tunasisitiza, pamoja kuna investment kubwa, tunajua uwekezaji mkubwa kwenye kuwaruhusu watu kwenda kusomea ubingwa, lakini bado hichi kimekuwa kikwazo. Mheshimiwa mgeni rasmi, tunakubaliana na mimi kwa tumeona kwenye sehemu nyingi tu nafasi zinatolewa za kusoma lakini hazijazwi kwa sababu ya utaratibu. Kwa hiyo tulikuwa tunaomba ikiwezekana utaratibu uweze kufikiriwa ili tuweze kupata madaktari bingwa. Lakini pia kwa sisi upande wa surgery tuna chuo chetu cha COSEX ambacho siku nyingi tumejaribu kuona kitambuliwe, kwa sababu ni utaratibu mmoja mrahisi wa kuweza kupata madaktari bingwa kwenye fani ya upasuaji. Mheshimiwa mgeni rasmi, sekta ya afya kama tunavyojua, kuna ule utaratibu wetu wa swap ambao na sisi tulihusika kutengeneza. Kwa hiyo tunaona unapoendelea vizuri, lakini tunazidi kusisitiza kwenye yale malengo yetu tuliyokubaliana yaweze kuwekewa uzito. Aidha, Mheshimiwa mgeni rasmi, bado kuna changamoto ya mgao wa madaktari katika maeneo. Kuna maeneo fulani bado tunaona yana wingi zaidi, pamoja ya kuwa na uchache wetu, lakini mgao bado haujakaa vizuri. Kwa hiyo tumekuwa tukisisitiza serikali iangalie jinsi ya kutogawanya, na tulikuwa tunapenda utaratibu mzuri ufanyike kwa wale wanaoanza, basi waanze kwenye vituo vile vya chini, waanze kupata experience mpaka wanapofika, kadri wanapozidi kukua ndio wanapanda kwenda kwenye hospitali za taifa na za kikanda, na sio mtu anaanza moja kwa moja kwenye hospitali ya taifa na kikanda hajajua bado jinsi ya kuanza na changamoto zile za chini ili aanze kupata experience. Zamani huko miaka nyuma kulikuwa na utaratibu, wale waliosoma zamani na ndio nayo unajua, walikuwa naenda kwanza, mnaanza kwanza huko kwenye hospitali za wilaya, wapi ukipata ujuzi ndio mnaanza kusogea kwenye hospitali kubwa. Kwa hilo tulikuwa tunaomba liangaliwe tena ili kuweza kuweka utaratibu mzuri. Lingine la mwisho, tuendelee tena kukushukuru kwa kuweza kuja kwenye kongamano letu kufungulia. Najua kama tulivyosema, taarifa yetu imekuja mwisho sana, lakini tunaomba radhi kwa hilo, ila tunakushukuru kwa kufika kwako. Aidha, lingine tunaendelea kuomba tena uwezekano, tunajua sasa hivi tuna changamoto kubwa, wagonjwa wetu wengi wanashindwa kumudu, kama tulivyosema mwanzo, wanashindwa kumudu hizo gharama. Kwa hiyo tunaendelea kusisitiza hilo tena, endelee kuangaliwa. Aidha, Mheshimiwa mgeni rasmi, nipende kutoa shukrani zangu za dhati, kama unavyojua Mheshimiwa mgeni rasmi, ili kufanikisha hili jambo letu tumekuwa na wadau wetu ambao wamekuwa kutusaidia na kadri tunapoenda tunaona kabisa jinsi tunapokwenda na wao pia wana changamoto zao na wanazidi wakifungua moja baada ya nyingine. Kwa hiyo tuombe nao serikali waweze kuangalia nao jinsi ya kuongezea nguvu ili tuweze kufanya hii mikutano mbalimbali, lakini na pia tuweze kufanya huu utaratibu wetu tunaosema wa kutoa huduma za kibobezi kabla ya wiki moja au mbili kabla ya mkutano. Pia tumekuwa tukisikiliza pia hizi huduma za kimkoba ziendelee kutiliwa nguvu. Kama unavyoona Mheshimiwa mgeni rasmi, na wewe utakuwa shahidi, umeona wagonjwa wengi waliojitokeza. Ile awamu ya kwanza tulipofanya ile kambi ya madaktari wa daktari bingwa Dr. Samia, tuliweza kuona hapa tu Morogoro peke yake kuna wagonjwa zaidi ya 3,000. Tena tumekwenda kwenye hizi kambi mbalimbali, tumeona pia kupitia halmashauri mbalimbali upande wa upasuaji wagonjwa zaidi ya 500. Kwa hiyo inatuonesha kuwa kuna mahitaji sana ya huduma zetu. Kwa hiyo tunazidi kusisitiza huduma hizi ziendelee kutolewa, nasi tuko tayari kushirikiana na serikali kwenye hilo. Kwa hiyo turudi tena kuwashukuru wadau zetu mbalimbali watusaidia kufanikisha shughuli kuanzia kwenye kambi zetu mpaka kwenye mkutano huu. Bila kusahau kuna MCT, kuna Gusu, kuna Azuma, kuna hospitali ya taifa ya Muhimbili, kuna hospitali ya KCMC, kuna Mega Wingare, kuna Field Distributors, kuna hospitali ya rufaa ya mkoa ya Dodoma, hospitali ya rufaa ya mkoa ya Tumbi, na ofisi yako tukijumuisha na ofisi ya mkoa wamekuwa kutusaidia tokea mwanzo wa jambo hili. Kwa hiyo tunaendelea kuwashukuru, na wale ambao sikuwataja, lakini wote tunawashukuru sana sana kwa kutusaidia kufanikisha jambo letu hili. Kwa niaba ya chama hiki nitaomba baadaye Mheshimiwa mgeni rasmi upate nafasi ya kuwakabidhi vyeti na kuwashukuru na kutambua udhamini wao. Baada ya kusema haya, Mheshimiwa mgeni rasmi, nikukaribishe kuhudhuria kongamano letu hili, na niendelee kukushukuru tena kwa kufika kwako, na niwashukuru washiriki wote wa kongamano hili pamoja na vyombo vya habari ambao vinatukaza. Jamhuri ya Muungano wa Tanzania. Asanteni kwa kusikiliza.
Thank you very much, President, this opportunity to welcome Professor Akoko Larry, who will give a keynote address, and then after that I will invite Mr. President to invite the guests of honor.
Good morning, ladies and gentlemen, esteemed colleagues. I got support from failure to sleep. I just traveled from one overnight to be here on time. First, it's a pleasure to stand before you in my years growing as a young doctor and as a surgeon. This was not the right time in age to be giving keynote speech. We are used to gray hairs of people like Charles Nkoni, Patronia Miloi, my elder Nungu, and the likes to be giving keynote speech. So when I was asked to give a keynote address, it gave me lots of challenges. And first I had to rephrase the theme of the conference. And I rephrased it without losing the meaning and called it Challenges and Opportunities of Delivering Safe Surgical Care in Low and Middle Income Countries during the Fourth Industrial Revolution. So as I stand before you today at this TSA conference, the theme is know that we are in the fourth industrial revolution. So I had to look back and ask how many revolutions and what marked each and where. And I realized that we did not even enter the third industrial revolution as surgeons. And now we are talking about the fourth industrial revolution. So what would be the challenges that we face as a surgical community and as a country towards going into the fourth industrial revolution with safe surgery? First and foremost is a shortage of trained surgical personnel. And this shortage is aggravated by poor distribution of personnel, such that we still shift our roles at the district level to medical officers, and we feel comfortable with that. And in the regional hospitals, where the government establishment states that we need surgeons, some of our regions have no surgeons. If they do, they have one. If you only have one surgeon, who is a human being traveling sick, they can't offer services, surgical services 24/7, 12 months in a year. So they'll be available maybe for 30 or 40% of the year. So that's a serious shortage. Inadequate infrastructure to support safe surgery is another big problem. We have seen rapid increase in physical infrastructure. We have increased regional hospitals. We have increased district hospitals to deliver surgery. We have surgery taking place at the health centers. But what is the infrastructure that's there to support surgery? Is it adequate? Limited access to essential surgical supplies is a big problem. Worsened during the COVID pandemic, when countries that are manufacturing locked themselves with their produce, and we were left without manufacturing capacity, going into the fourth industrial revolution without capacity to manufacture essential surgical supplies. High cost of surgical services, as has been said by the President in the speech. And for the first time, we are seeing people going to the newspaper for support to take the dead bodies of their beloved ones because they could not pay the hospital fees associated with care. The ICU services post-surgery has become too expensive for many. The surgical devices used to offer safe surgery are too expensive. A craniotomy before you have a brain surgery would cost about 900,000 that many patients would not afford. Only 8% of the population is insured. 92% are not insured. Of the 8% that are insured, 92% are insured by the insurance fund, which we know with its financial crisis and readjustment of prices that they did recently. It's not a very good news towards universal health insurance coverage for the whole population. But on top of all these problems, we have one of the most rapidly growing population in a way that even if you are to ensure all working class to provide work for everybody in Tanzania, majority of the population are dependents. They are either young, still in school, and very few are elderly. And this is a great challenge to a country, a young country like Tanzania. In the light of these challenges, it is important that we embrace the opportunities presented by the fourth industrial revolution, which is characterized by rapid technological advancements such as artificial intelligence, robotics, and telemedicine. Are we ready for artificial intelligence in medicine? Are we ready for robotics as a country? Are we ready for telemedicine? When we're talking about all this, we know there was a drive to have telemedicine facilities installed in all facilities in the country 10 years ago. And we using it. The only active ECHO program is the one used by Zombe, I guess. And none of the medical schools has any active ECHO program. You know, the Indian medical tourism has established telemedicine facilities within the country where patients go and they talk to their doctor immediately and they get an opinion. What are we doing? Are we supporting our colleagues working at lower level facilities? What about robotics? Don't talk about robots. While we have not even used laparoscopy extensively, only a handful of hospitals have laparoscopic services. So, these challenges have the potential to revolutionize the delivery of surgical care, making it safer, more efficient, and more accessible if we adopt the fourth industrial revolution. One of the most promising applications of fourth industrial revolution in surgical care, as I said earlier, is telemedicine, allowing surgeons to consult with patients remotely, diagnose conditions, and provide treatment recommendations. Our colleague in Singida, Dr. Nuru, was blessed to have a mentor in the US and was given Google glasses. So he can operate, and the mentor located very far away in the US will be seeing him step by step in the procedure and will be giving both verbal instructions on how to proceed with surgery. And is now very independent. And this is use of technology. This is where we should head. Technology is particularly valuable in rural and underserved areas where access to surgical care is limited. Unfortunately, when we bring technology, we bring it to tertiary level. And we want to use it at tertiary level. And we don't want to use it to support the lower levels where we are absent. Another promising application of fourth industrial revolution is the use of artificial intelligence in surgical planning and execution. AI can be used to create detailed 3D models of patients' anatomy, which can aid surgeons to plan complex procedures and minimize risk. We have a pelvic model, which was donated to us from University of California, San Francisco, that can be used to learn and train and exercise how to do kidney transplant. And all these are advantages and many more that we can do with the use of artificial intelligence. AI can also be used to guide surgical robots, which can perform procedures with greater precision and accuracy than human surgeons. All this poses a threat to surgeons' career and employment, but nevertheless, we must embrace it for the safety of our surgical services. Of course, the implementation of fourth industrial revolution technologies in surgical care also present challenges. These challenges include the need for reliable internet connectivity, the cost of technology, and the need for surgeons to adapt to the new ways of working. When you are over-reliant on internet, as we saw during I think it was last month, when we had outages of internet in the whole country and especially in the whole Horn of Africa, and you are over-reliant on technology, you can understand the mess that you would go into. So it's good for countries to look at reliable internet connectivities. I think it's time to let go cable and use satellite internet and the speed. However, I believe that the benefits of fourth industrial revolution far outweigh the challenges that I've just mentioned. And so by embracing these technologies, we can improve the quality, efficiency, and accessibility of surgical care in Tanzania and similarly in other low and middle income countries. So to understand how we can apply the fourth industrial revolution, we need to look at the current landscape of surgical care in Tanzania. And we need to begin by acknowledging the significant challenges that we face. As I have said, limited resources, we improvise a lot, but are we innovating in our improvisation? When we have shortage of skilled surgeons, how can we use fourth industrial revolution to bridge this gap? What about anesthesia provision? What about nurses? And all these create bottlenecks for timely and accessible surgery for our population. We have disparities in infrastructure and equipment across regions, which exacerbate some of these challenges. We still have limitations in how we deal with surgical complication rates and poor patient outcomes. We are not collecting data, so we don't know where we are as a country. We are still reliant on scalpel, sutures, and at least a monopolar as the sole energy device in our surgery, while the whole world has moved into high-tech energy devices. With less training in adoption and use of technology, surgery cannot be done safely in our setting. It's very limited. Furthermore, the burden of communicable and non-communicable diseases continues to rise, placing even greater demand on our already stretched surgical workforce. So the question comes, how can we navigate the integration of technology in surgical care? And we need to build capacity, invest in digital infrastructure, and prioritize on data privacy and security. So by building capacity, we need to invest in training the healthcare workforce to effectively use emerging technologies. And this will require that we create space during training or post-training for graduates and trainees to move around the globe and see what's new in their areas of specialization and come and see what's available locally that they can use to adapt, develop educational programs and resources to upskill surgeons and other healthcare professionals, and of most importance, we need to foster trust in technology among patients. Because if you come with technology and they don't have trust in it, you are going to fail. What we need to do to invest in digital infrastructure? We need to expand internet access, especially in the rural communities, and we need to implement a robust healthcare IT system for seamless integration of technology. As you remember, in the last annual general meeting, we had a symposium we were looking at the possibility of a patient not repeating investigations that we've already done elsewhere. Whether the systems can communicate such that when a patient is seen in Arusha and the next time he's seen in Morogoro, the moment he reports in Morogoro, the doctor in Morogoro should be able to access all the work that have been done previously so that we avoid repetition. This is something we need to continue discussing, especially because it's within our reach in the fourth industrial revolution. Robust data protection measures must be in place to safeguard patient confidentiality and ensure ethical use of medical data and materials. We now see that we can transport materials from Tanzania to India, to Europe, to US for diagnostic purposes. What else are they being used for? We don't know. And this requires ethical consideration. If you are doing research, you will need material transfer agreements. If you are diagnostic, none of this is being required, and this is a potential area of abuse in the future and need to be looked at. But above all that I've spoken about, technology will be useless if it does not take into account equity and affordability. And this is one of the greatest problems that we have. As I noted earlier with the craniotomy. When craniotomy was safely done with the bar hole and the giggle saw, and you don't know the cost of doing it. And now the cost is known because they're using a drill, and it's 900,000. Is it affordable? If I come acutely and I'm dying and I don't have 900,000, what will you do? It's good technology, but the society is poor, they can't afford it. So you need to find what's working in your community so that each patient will get equitably and affordably. So we have to promote equitable access, and this is one of our main objectives as an association. And that's why during this AGM, we had an outreach. We call it giving back to the community. You want to reach people who have not been reached. But we'd like these people to be reached constantly. They should not wait, suffer until another surgical conference or another outreach program starts in their region. Avoid creating disparities where only privileged populations benefit. Like, we have moved into transplant. None of us here will get a transplant because you are a doctor if you can't pay. Because your insurance will only pay a portion of it. Is it something we need? Should we look at what are the cost drivers? Can we look at the benefits of keeping a patient on dialysis versus transplanting them? Which one is better for the insurance? Because if you are not transplanted, you are on dialysis. Which one is better? Which one is more expensive? So this is our role. These are research areas that we need to look at. We need to also look at research into the cost of surgical services that we offer. We know we have been with disputes with NHIF on cost of surgical services. It's time that in our respective specialties, we look at how we cost our surgical services so that we have equitable and affordable services. But to achieve all this, because we don't have technology, when the African heads of states met in Korea at the invitation of the Korean government, I read in the newspaper that Korea did not sign any technology transfer agreement. Without technology transfer agreements, you will continue to be dependent on imported products and look at the dollar fluctuation rate that we have now. Even if you have a better costing model, it will not work. Because you cost it today at a rate that will not be the same rate as next week. So that's the challenge. But collaboration and smart collaboration is the key to entering the fourth industrial revolution. And surgeons must learn advocacy language and reach out to industry and influential persons in the society, trying to explain why you need this technology to come. Policymakers are necessary to engage with. These are members of parliament, councillors, and they need to understand and buy in on investing in technology to accelerate self-surgery provision. Unfortunately, we study in isolation. You will not walk into the fourth industrial revolution without the engineers. In the developed countries, engineers will walk into your operating room, into your practice, and they will see the difficulties you are having with your surgery, and they will come with a solution and tell you, try this one. We are used to the same type of levels, same curve. Whether you are suturing the skin or you are suturing something else. So we need to embrace working together, teamwork, bring in the biomedical team, the material engineers, the electronics, the electrical to the operating room and work with them. Public health officials are very important to facilitate buy-in and acceptance of technology by the community. But of most importance, which you are not doing, is the public sector buy-in. All advancement in surgical provision and medical provision in our country is spearheaded by the government facilities, and they are expensive because of the bureaucracies of procurement and the like, even exacerbate the costs. The private sector is left behind. Even when you want to produce technology, you need the private sector to produce it. They are flexible. They form collaborations easily across the borders. So we need to promote private sector engagement, especially in our context. But investing in our workforce is also very important. Over the years, we have done great work in developing surgical workforce, starting with general surgery as the only discipline in the country, some specializing in orthopedics and trauma, ENT, urology, neurosurgery, and pediatric surgery. We now have early specialization in orthopedic and traumatology from MD program, ENT, urology. Now more recently we are going to have an MD in neurosurgery for the first time. That will be. In addition, we have added new subspecialties such as surgical gastroenterology, plastic and reconstructive surgery, cardiothoracic surgery, and pediatric surgery as subspecialization, and many more will follow. With the emergence of new specialties, the role and position of general surgery has come to light with significant distortions on whether it is still needed. Yes, we still need it, that's my position. A very strong general surgery program as a platform for further subspecialization in areas such as abdominal transplant, bariatric surgery, gastrointestinal surgery, vascular, just to mention a few. On the same note, early specialization program should have opened avenues for further subspecialization in the respective fields of orthopedics and traumatology, ENT, urology, and in the future neurosurgery. It is not my expectation that in the next 5 years we'll only be seeing urologists as MD urology. We expect to see subspecializations within urology, subspecializations within orthopedic and trauma. We're already having people specializing in arthroplasty. What else? Spine surgery. What else? So we need to open up. That's why you specialize early, so that you subspecialize, so that you have a terminal degree as a subspecialization of what you took as initial specialization. But as a society, we also need to address the Tanzania Commission for University, which dictates what an education is. TCU says terminal degree is PhD. And we all know that with the PhD post-MD general surgery, you are not going to improve what you are doing as a specialist. What about our subspecializations? It's time we make noise that our subspecializations are also terminal, synonymous and equivalent to the PhD program. So as a result, if we don't make this noise, we are going to have, within the profession brain drain, you are going to move surgeons into bench researchers, and they're not going to do surgery. That will be bad, as we need more numbers during the 4th Industrial Revolution. Let us use this conference as a springboard for action. Let us move forward with a spirit of innovation and a commitment to building a future where safe and effective surgery is within reach of every Tanzanian. Thank you very much.
Thank you very much, Professor Akoko. I would like to take this opportunity to recognize the presence of Professor Mkoni, who was once President of Tanzania Surgical Association. I would like to take this opportunity also to acknowledge the presence of Professor Kahamba, who was once President of So after this, I would like to take this opportunity to welcome President of Tanzania Surgical Association to introduce our guest of honor and welcome him to give his address.
Asante sana Utungoma, Mheshimiwa mgeni rasmi, kwa heshima na taazima nichukue nafasi kukukaribisha kuhutubia hadhara hii ambao tuko tayari kusikiliza. Karibu sana. Jamhuri ya Muungano wa Tanzania. Mheshimiwa, naomba niite Rais wa TSA, nisije nikanukuliwa vibaya, lakini nitambue uwepo wa viongozi wote meza kuu, washiriki wa kikao hiki, wadau ambao wameshiriki pia kufacilitate kikao hiki, lakini pia waandishi wa habari. Ndugu zangu, mimi kwa jina naitwa Usirie Ukio, jina la Kibantu,
sasa natumika kama mganga mkuu wa mkoa wa Morogoro. Nichukue fursa hii sana na adhimu kuwakaribisha sana Morogoro. Inawezekana niko hapa kwa bahati mbaya, lakini mapenzi yangu. Natambua kwamba hiki sio kikao cha kwanza kufanyika cha asasi za kitaaluma. Tumekuwa na vikao hivi kuanzia wiki iliyopita, vingine siweza kushiriki kwa sababu ya mambo mengi, lakini namshukuru Mungu pia kwamba nimepata fursa hii ya kuja kushiriki hapa. Aliyetakiwa kuja hapa ni katibu mkuu wizarani. Katibu mkuu akamkasimisha katibu tawala. Katibu tawala akaniambia, dokta, nimerudi jana usiku, akaniambia sasa wewe beba hiyo simu. Kwa hiyo niko hapa kwa niaba ya Dr. G. Lakini mimi kama mtoa huduma mwenzenu nimefarijika sana kuja hapa, na kwa heshima kubwa na kwa unyenyekevu mkubwa, mimi naomba ni wasimamishe watu niliopanda kwa mabega yao kufika hapa, na napenda kuchukua fursa hii popote nilipo, kwa sababu bila kufanya hivyo unaweza usipate fursa nyingine. Na wajua kwa majina niliwaona tu nikaanza kusmile. Wa kwanza ni Profesa Kahamba. Baba naomba uendelee kusimama kwa heshima. Wa pili ni Profesa Giloy. Profesa Boni. Profesa Nuhu. Inawezekana mnikumbuki kabisa na sio shida, lakini watu hawa kila mmoja amegusa maisha yangu, kwa sababu nimepita kwenye maeneo ambao walinifundisha wao kama wao, na ninakumbuka maneno ambayo waliniambia wakati nimepita katika muda mchache niliokaa nao. Na ninakumbuka nimuuliza president, kuna watu nataka niwaone. Nilimuuliza Profesa Kahamba, nikaona jina la Petronila Kingoi, nikasema alhamdulillah. Lakini nilifurahishwa zaidi nilipoona Dr. Nkoli. Dr. Nkoli nilikuwa nakaa naye sana kujili. Hawezi kunikumbuka. Najua hawezi kunikumbuka. Na marehemu Profesa Aziz. Watu ambao walikuwa wanamkimbilia mimi ndio nilikuwa namkimbilia. Kwa hiyo ningependa mfahamu hivyo. Na niliwakumbuka sana kwa sababu nilianza kazi sehemu inaitwa Simanjiro. Kule nilikuwa first grade na second on call. Kwa skills zenu, competence na professionalism niliona manufaa yake kule. Kwa niko hapa kwa sababu tu ya matokeo ya kazi. Lakini nataka mtambue kwamba mimi binafsi nawathamini sana. Mmegusa maisha kipekee kabisa. Personal, sio katika group, personal. Na at one point nimejengea interest kubwa sana kwa sasa. Nashukuru sana. Sema mkondo wa maisha ukiamua hivi, mfumo unaweza ukataka iwe tofauti. Kwa heshima naomba mkae. Lakini kuna watu ambao nawaita wapambanaji wenzangu ambao pia tulipita kwenye mikono yenu. Profesa Koko. Hapo ndio kusimama. Profesa Mwashamba. Lakini nimeona Dr. Ali Mwamba mahali. Hawa tulikuwa nao Ng'ande pamoja. Tuligraduate wote tarehe 4 Disemba 2004. Kwa hawa ni colleagues in business. We have been through thick and thin. Na nimefurahishwa sana kwa karibuni sana Morogoro. Najua mlikuwa mnapita kimya kimya, lakini leo ni wadau. Nawashukuru. Ndugu zangu, nafurahishwa. Maisha yana mambo mengi sana. Na kuna wakati tulikuwa na event na Profesa Msele, eti mimi ndo nikawa mgeni rasmi. Nikamwambia mkuu, mimi nitakuwa tu MC, wewe ndo utakuwa mgeni wa heshima. Kwa hiyo tukabadilisha seats. Kwa hiyo taratibu zingeweza kuruhusu mimi ningewaita. Alafu mimi ni facilitate yale ambayo yanatakiwa kufanyika hapo. Lakini mimi leo ni mtuma. Kwa maana ya kwamba sitakiwi kujiachia sana, kwa sababu address ya mgeni rasmi natakuwa address issues ambazo nyingine nimeziraise. Ndio na mimi nilikuwa na yangu ya kichwani mengi, lakini keynote nadhani imeaddress mambo mengi sana msingi. Nilikuwa na chat na daktari wa IT pale, akamwambia everything that nilikuwa nataka ni raise nje ya hotuba imekuwa addressed na keynote, na ni challenges ambazo ni lazima tuzifanyie kazi. Na kwa wale wachache ambao maybe hawajui, sijawahi kuona investment kubwa kwenye afya katika utendaji wangu kama kipindi hiki cha miaka 3 minne. Huo ndio ukweli. Na kwa wale waliobahatika kupita kwenye vituo vya afya na zahanati na hospitali za wilaya, the investment is immense. Kubwa sana. Tofauti na tulipoanza kazi, improvisations zilikuwa nyingi. Kwa hiyo working environment ya watu huduma wengi imeboreka. Thanks and credit to the government. Chini ya Mheshimiwa Rais. Na ni vitu ambavyo najua wengi wetu tulikuwa tunatamani vitokee. Ila kwa kupiga makelele au kutoka kuvifuata huko vilivyo. Lakini sasa tumeletewa. Kazi kubwa tulionayo ni kuhakikisha service delivery inakuwa na quality inayotakiwa, lakini accessible. That's the challenge. Naweza nikasema vyote tulivyosema in those two particulars. Lakini kifupi niseme kwamba kikao kimefunguliwa, na ningekuwa mimi ningeishia hapo, niwaruhusu kuendelea. Lakini kwa sababu nimetumwa, nitaomba nisome pia hotuba ambayo imetumwa kwangu, nisome kwa niaba ya Katibu Mkuu wa Wizara ya Afya, na yale ambayo yamekuwa raised hapo nitarudisha katika mkondo huo in summary form, nimtumie kama mambo yaliyotokana na hichi kikao. Lakini kama kuna mengine tutasubiri mpaka mwisho wa kikao, ili na mimi ni forward katika capacity to mrejesho. Kwa kama mtaondoka au mtatoa kabla mjaondoka, in summary, mimi ningeomba niyapate nitume kwa CMO na Katibu Mkuu kama procedures zilizotoka kwenye kikao na kama mrejesho wa kazi walionitu. Kwa sababu haita make sense nisome speech niondoke bila kujua procedures na yaliyotokana na hichi kikao. Kama itawapendeza mtamaliza mapema Ijumaa au Jumatatu ijayo, itakapowapendeza. Sasa kwa ufupi, na nashukuru hotuba sio ndefu, naomba nisome kama ilivyo, ili message iwe delivered, wala nisiichachue kwa maana yoyote. Ndugu wanataaluma, awali ya yote nimshukuru Mola muumba wa vyote kutuwezesha kuiona siku ya leo na kujumuika pamoja nanyi katika siku hii muhimu kwenu kitaaluma. Pia asanteni kwa kunikaribisha kuwa mgeni rasmi katika kongamano lenu la kisayansi. Ndugu wanataaluma, mimi nikiwa kama Katibu Mkuu nina uthamini sana mchango wenu katika gurudumu la afya nchini. Hivyo nisingeweza kukosa au kutuma mwakilishi kuhudhuria kongamano lenu pasipokuwa na sababu muhimu. Majukumu ni mengi, lakini hili la kwenu ni kipaumbele nambari 1. Ndugu wapasuaji, nishtuko kidogo na ile neno, lakini nitawaachia. Sisi kama serikali tumevutiwa sana utulivu mliokuwa nao katika kipindi cha miaka 30 ya uwepo wenu na ushirikiano mnaotoa serikalini kuchangia katika kuboresha huduma za afya nchini. Nami niwapongeze viongozi wenu wastaafu waliomo humu ndani kama Profesa Kahamba, Dr. Petronia Ngiloi, Dr. Samuel Ndungu, Dr. Catherine Mumongo ambaye hayuko hapa, na Profesa Ngoni. Ndugu wapasuaji, nafurahishwa sana na huduma mnazoendelea kutoa za upasuaji, ama katika hospitali zenu ama kwa njia ya kambi maalum za upasuaji. Sisi tutaboresha namna ya kuwashirikisha vizuri zaidi ili kuweza kujengeana uwezo kwa ngazi tofauti za utoaji huduma. Naomba kupongeza pia moyo wenu wa kujitolea, kwani hakuna gharama yoyote inayoweza kufidia kujitolea kwenu. Wizara tutaangalia namna nzuri zaidi ya kufadhili shughuli zenu za kambi za upasuaji ili tusisubirie huduma za mara moja kwa mwaka, bali ziwe endelevu siku hadi siku. Serikali inayoongozwa na mama yetu Dr. Samia Suluhu Hassan, Rais wa Jamhuri ya Muungano wa Tanzania, ni sikivu na inawajali sana katika kazi zenu za kila siku pamoja na kambi hizi mnazoziandaa. Ndugu wanataaluma, kuanzia mwaka huu wa fedha, serikali imelenga kushusha gharama zote za huduma zikiwemo za upasuaji. Hii ni katika kuwapunguzia wananchi gharama kubwa za upasuaji na huduma zingine za afya. Tutaendelea kutekeleza mpango wa kitaifa wa kuboresha huduma za upasuaji na nusu kaputi. Miundombinu yote inayohitajika kuweka tayari, sasa kilichobaki ni kusomesha, kupeleka wataalamu wa upasuaji na nusu kaputi. Nia na azma ya kufanikisha mpango ni mwaka 2030 na kasi hii itaongezwa zaidi. Ndugu wapasuaji, hili na nyie na wateja wengine wa bima ya afya ambao pia ni watumishi wa afya limeshafanywa kazi. Maelekezo ya serikali ni kwamba mwajiri atachangia na sio mtumishi kuchangia gharama, ama mwajiri awalipia watumishi wake executive card kama wanapofanya JKCI na taasisi zingine. Hizo fedha wanazochangia ni za serikali na sio za kwao. Hivyo ni agizo ambao hawajatekeleza wafanye hivyo haraka sana. Inasikitisha kuona mtumishi hasa wa afya akikosa huduma ambayo yeye mwenyewe anaitoa. Lakini pia tutashirikisha sekta binafsi itoe hizi huduma kubwa za kibingwa ili kuleta ushindani na kushusha gharama za tiba nchini. Ndugu wapasuaji, serikali inatambua mabadiliko ya vitita yanayoathiri sekta ya upasuaji. Hivyo serikali yetu sikivu inayoongozwa na Mheshimiwa Dr. Samia Suluhu Hassan inaendelea kuifanyia maboresho. Ndugu wapasuaji, naomba mtusaidie kukemea tabia zisizokubalika kama lugha mbaya, rushwa na kufanya kazi pasipo na leseni. Kumekuwepo na malalamiko mengi sana kuhusu wagonjwa kudaiwa rushwa juu ya gharama kubwa ambazo tayari zipo. Serikali ipo mbele kuwezesha chama katika kulea maadili ya kitaaluma na mapendekezo yote yanayolenga hili yatafanywa kazi haraka sana. Wengi wenu ni wazuri sana, tena sana, lakini wapo wachache wanaoharibia tasnia yenu. Ndugu wanataaluma, hili la kujiendeleza ni mjadala uliokuwepo kwa kipindi kirefu sana. Kama tusomeshe kwa kutumia vyuo au tutumie njia mbadala. Tanzania sio kisiwa. Hivyo serikali iko tayari kupokea mapendekezo bora ya namna nzuri ya kuendeleza taaluma zenu za upasuaji na ubobezi wake. Najua baraza limeandaa mwongozo wa namna ya kutambua umahiri wa ubobezi. Nitoe wito kuipa ushirikiano baraza la lenu katika kusimamia hili. Pamekuwepo pia na malalamiko kuhusu ubingwa unaotolewa ughaibuni, kutokukidhi vigezo na wanataaluma kutokupewa leseni huko ughaibuni, hivyo kutilia shaka kama kweli wanasoma kwa vitendo. Serikali itafuatilia na haitasita kuchukua hatua kwa maslahi mapana ya taifa na usalama wa nchi. Ndugu wapasuaji, nimeona jinsi serikali inavyotumia pesa za uviko 19 kama nilivyokwisha ainisha kuboresha huduma za dharura, ICU, upasuaji, upatikanaji wa oxygen, vifaa vya uchunguzi kama MRI kwa hospitali za rufaa na za kanda, CT scan kwa hospitali zote za rufaa na mikoa, ultrasound na x-ray pamoja na mengine ambayo mnayajua. Huku ni katika kujiandaa na majanga, lakini panapokuwa hakuna majanga hutumika kuboresha huduma nyingine. Nimefahamika kuwa nanyi mmelitambua hilo na msisitize kuonyesha maeneo mengine ya kuboresha zaidi katika nchi kao. Ndugu wanataaluma, hili na mgawanyiko limekuwa likisumbua siku hadi siku, lakini sasa tunachukua hatua. Tunaenda kuwasambaza watoa huduma tulionao ili kukidhi mahitaji ya serikali. Tunaomba mtupe ushirikiano kama ambavyo mmefanya siku zote. Wote mnaohudumia na wananchi wale popote mtakapopelekwa. Naomba pasikuwepo na nongwa ya aina yoyote, tena niko bold. Pindi mtakapoona mmehamishwa kupelekwa mkoa tofauti na ulipo, Tutaweka ikao na kusimamia vyema ili kuondoa mrundikano wa watoa huduma sehemu moja. Ndugu wapasuaji, niwatakie kongamano jema na mtupe mrejesho kwa yale yote ambayo mngependa tuwafanyie kazi ili kuboresha zaidi huduma zetu za kibingwa. Nitafikisha salamu zenu kwa Mheshimiwa Waziri Umi Mwalimu. Ningependa kujumuika nanyi, lakini kwa wingi wa majukumu mtashindwa kufanya hivyo, lakini huku kuna serikali itasikiliza na tutayafanyia kazi. Mwisho, niwashukuru wadhamini wenu wote waliofanikisha kongamano hili. Niwasihi msichoke kuwadhamini, kwani kufanya hivyo mnasaidia serikali, kwani hili ni jukumu letu sote. Mimi kwa haya machache nimeleta message kama ilivyo, lakini niombe sana yatakayotokana na hichi kikao yapate Mheshimiwa Rais na mimi niyawasilishe kama mrejesho. Nawashukuru na natokea kikao chenu. Asante sana.
Thank you, Guest of Honor, Dr. Kusilie, for the very encouraging speech that you have given us. I'd like to take this opportunity to welcome Professor Petronino Aguiloi to give a vote of thanks.
Habari za asubuhi. Mimi kazi niliopewa ni ndogo sana ya kumshukuru mgeni wetu rasmi Mheshimiwa Dr. Kusilie Ukio, mganga mkuu wa mkoa wa Morogoro, mkoa wenye mji kasoro bahari, lakini naamini sasa hivi nasikia mna bahari ya Bingu. Kwa hiyo jiji limekamilika. Awali ya yote ni kushukuru sana pia kwa kushukuru wazee tuliomo humu ndani, na pia kutukumbusha kwamba tangu chama chetu kianzishwe tumefikisha miaka 30 mwaka huu, maana tangu 1994 na sasa tuna miaka 30. Tunashukuru pia kukumbuka marais wastaafu, kwa sababu nadhani vijana waliopo sasa tunaanza kupoteza kumbukumbu jinsi ambavyo chama kinaendelea. Profesa Mkoni alikuwa rais wa 3. Bahati nzuri hata founder president bado yupo, Profesa Bernard Kirei. Alifuatiliwa na Profesa Leonard Lema ambaye alishatangulia mbele ya haki. Na baada ya Profesa Mkoni alikuwa Dr. Robert Mhina. Na baada ya Robert Mhina mimi ndio nilipokea kijiti nikiwa rais wa 5 katika mlolongo huo. Na baada yangu alikuja Dr. Samuel Kitugi Nuhu ambaye yuko hapa. Na baada ya Dr. Nuhu alifuatia Dr. Paul Mariale ambaye shatangulia mbele ya haki. Na baada yake alikuja Dr. Catherine Mungongo. Na baada ya hapo alikuja Dr. Professor Larry Akoko. Na baada ya Larry Akoko ndo tunaye sitting president Dr. Amani Malima. Kwa hiyo katika miaka 30 tunaona mtiririko na mlolongo wa kuimarisha chama. Kumekuwa hakuna ugomvi wa kugombania madaraka, kwa sababu kama alivyokaa Dr. Malima hapo, tayari Dr. Olivia pembeni yake anasubiri kukalia kiti. Kwa hiyo ni jambo linaenda katika demokrasia ya hali ya juu. Tunakushukuru sana mgeni rasmi kwa mambo muhimu ambayo umeangalia katika sekta ya upasuaji na ahadi ambazo umetoa kufikisha maombi yetu, na nikiamini kwamba wewe pia ni kati ya kundi la maamuzi, decision makers. nyie ndio mko huku jikoni, kwa hiyo mnapoenda wizarani kuwapa changamoto ambazo ziko katika mikoa yenu. Na kwa sekta ya upasuaji tunashukuru sana kama ilivyotoka kwenye keynote address, speech ya rais na baadaye ya kwako, kwamba serikali inajitahidi kweli kuboresha maeneo na tumeyaona, ingawa bado safari yetu ni ndefu. Pia tulipopata fursa ya kupata pesa za uviko wa 19, kwa kweli pale ndio tumeona hata hospitali za mikoa zimeweza kupata ICU na kuboresha theater. Mimi binafsi wakati nikiwa rais mwaka 2007 tulifanya surgical camp hapa Morogoro na mkutano tulifanyia Ifakara. Na wakati huu nimerudi mara ya pili, kwa kweli nimeona mabadiliko makubwa sana. Ile 2007 nilipoingia theater nilitaka kuzimia, lakini walau nilipoingia miaka 17 sasa iliyopita, kwa sasa hivi walau kunatia moyo, ingawaje bado hasa kwenye swala la staffing. Naomba hilo mliangalie sana, kwa sababu kumekuwa na shida kwamba daktari anafanya upasuaji lakini hamna scrubness, sio kitu cha kawaida. Kwa hiyo tuangalie katika vifaa na staffing, bado tatizo ni kubwa. Alafu pia kwenye cost kama walivyozungumza tunaboresha, lakini hatuja create access. Kwa hiyo wagonjwa wengi wameshindwa kupata hata huduma yetu sisi binafsi kwa sababu ya kushindwa kulipia. Kwa hiyo namba hilo mkaliangalie sana kwa mapana yake kama walivyoahidi. Tushukuru sana wizara kwa kujali kushiriki katika mkutano wetu, pamoja na shughuli nyingi. Wewe umepewa short notice na bado ukaona umuhimu wa kuwepo na sisi, kwa sababu pia ungeweza kudelegate mtu mwingine, lakini umekuja wewe mwenyewe kwa sababu uko in direct contact na katibu mkuu. Tunashukuru sana kwamba umegusia swala la HIV. Kwa kweli ule ni mwiba. Nadhani kuongea kwa kifupi hapa haitoshi, lakini kwa kuwa umelibeba, naamini mapendekezo ambayo tutatoa katika mkutano wetu huu basi yatafikia decision makers kuona namna gani hili swala litatatuliwa. Tunapenda sana Watanzania wote regardless waliko waweze kupata huduma bora ya afya, particularly ya upasuaji. Iwe kwamba mtu kama anahitaji upasuaji, tiba ya upasuaji kwa kweli aipate, na aipate katika ile stahili na quality inayotakiwa. Kwa hilo tuishukuru sana wizara kwamba wametia msisitizo katika huduma quality, customer care nzuri. Hiyo tutaendelea kuzungumza sisi wenyewe na katika vijana wetu tunaowaelimisha kuwekeza sana kwenye customer care, kujali utu, na tulishirikiana na wizara ili kusudi huduma ya upasuaji iweze kuwa bora katika nchi yetu ya Tanzania, kuanzia kijijini mpaka ngazi ya taifa. Kwa hilo naomba nisipoteze muda kuweza kuyeyusha yale mazuri ulioahidi ili tuweze kuyafanyia kazi. Nashukuru sana na ndugu zangu madaktari wenzangu wote tulioko hapa katika mkutano huu. Kabla sijamaliza, naomba pia tushukuru wote ambao wametuwezesha kufanya huu mkutano, tukianza na Wizara ya Afya na Ustawi wa Jamii, Hospitali Kuu ya Mkoa wa Morogoro, Hospitali ya Taifa Muhimbili, Transworld Pharma, Kusum, Cardimed Africa, Anudha Limited, GSCH Ifakara, Mega Wicare, Radinesia Hospital, Kairuki Hospital, Zara Pharmaceutical, Tumbi Regional Referral Hospital, KCMC, Media na mwishoni Morena Hotel kwa kutupa nafasi hii ya kufanya mkutano hapa. Kwa hayo machache, nashukuru sana mgeni rasmi.
Thank you, Professor Ndiloi. I would like to take this opportunity to ask Mr. President, the guest of honor, to present certificates to our sponsors who have been supporting us throughout, from the beginning of the surgical camps up to when we are concluding our conference and annual general meeting. Nafikiri itakuwa hekima tukianza na wenyeji wetu, Morogoro Regional Referral Hospital. Kusum Healthcare. Cadmed Africa. Kairuki Hospital. Alafu Bahari Pharmaceutical Asogea. Then Zara Pharmaceutical Tanzania Limited. Tumbi Regional Referral Hospital. Alafu Transworld Pharma. Rabinisia Memorial Hospital. Rabinisia Memorial Hospital. Prado Medics. Alafu Muhimbili National Hospital. Muhimbili National Hospital. Muhimbili National Hospital. Then Mega We Care. Tafuatiwa na Good Samaritan Cancer Hospital. Then Global Medicine TV. Dodoma Regional Referral Hospital. another limited. Baada ya hapa chai nimeambiwa iko tayari, lakini dini rasmi tunaomba tukupe ofa ya kupiga na wale ambao walipanda kwenye mabega yao. Naomba na wale colleagues wake, Profesa Koko, Dr. Mwaka, alafu baada ya colleagues tunaomba council members wote tutasogea mbele. Tunaomba council members, alafu tutaomba Zanzibar team. Dr. Wilson, Dr. Wilson, Dr. Nuas, Seseja,
is about 5 millimeter thick. Around the spring is about 6 millimeter thick. The diameter of spring is about 195 millimeter. The surface code is about 51 millimeter. The challenge for classification is grade A. Pre-operative diagnosis is hepatitis B causes post-habitation, severe gastroesophageal bleeding, splenomegaly with hypersplenic ascites, type 2 diabetes, hypertension, chronic bronchitis. We made a comprehensive treatment for the patient. First is the ablation, together with intraoperative C-close endoscopy ligation, autologous cell vision, and anticoagulant. It's too far, so I stand here. The anticoagulant therapy is started on the post-operative day 3 to prevent port-vein system thrombosis. And endoscopic examination at the post-operative month 1. First month. So the important clinical significance of protecting the vagal lobe. Anterior vagal transgastric branch regulates gastric emptying function. Injury to gastric branch may lead to delayed gastric emptying. Anterior vagal transgastric branch manages the contraction of gallbladder glomerular secretion, destroying the hepatic branch, which innervates intrahepatic and extrahepatic bile duct, may result in stone formation. Posterior vagal transgastric branch dominates many abdominal organs, including small intestine, colon, liver, spleen, pancreas, kidney, and so on. The celiac branch, is also distributed in the pancreas and regulates its secretion function. And celiac branch preserving can avoid cell secretion disorders. Many patients complain of frequent diarrhea and secondary general weakness, which may lead to injury to celiac branch. So I will show the video about the operation. Okay, this video recorded my second robotic surgery for put happening bleeding. So first we dissociate the gastric ligament, then we continue to dissociate spleen gastric ligament. When we meeting a big vessel, we first use bipolar forceps. This is a good finger. Good finger is very important. It can provide good exposure that we can make the operation smoothly. Above the body of the pancreas, we try to find the splenic artery. Then we dissect the artery. This area is bleeding because there are many branches. So we should do carefully. So we can see the splenic wing. We use hemlock to grab the artery. Then we put the gauze above it. If they have a little bleeding, the gauze can hold it. Along the spleen, we cut the spleen gastric ligaments. So we use good finger again. We dissect the inferior artery and went together. So we use bipolar and harmonic to cut the artery and went together. So we dissociate the spleen conic ligaments. We can see good exposure can make the operation smoothly. So we dissociate. We usually put a small gauze around the operation area. When we need it, we can get it quickly. We continue to dissociate the spleen vessel ligaments. Then we use good finger again to get a good exposure. We can see robotic surgery can provide us a better exposure and better view than open operation. We continue to dissociate. Though we have complete dissect the spleen artery and went together. Yes. Finish. Then we use linear laparoscopic vascular stabber to transect the splenic blood vessel together, including artery and vein together. We continue to dissociate the short gastric vessel. Usually, we first every branch we first use bipolar, then use harmonic to cut. It's very safe. Don't use any hemlock or ligation. Then we continue to dissociate the splenophrenic ligaments. We can see good exposure can make the operation easy. So I always think the good exposure can make the operation easily to make and make the operation smoothly. Now we release the blood from the spleen and use local cell therapy, then transport for patient. Now we try to find the left gastric vessel. Then we along the gastric to try to find the left lower diaphragm. This operation I performed 2 years ago. Here we find the left lower diaphragm. Then we dissect the left surface of the distal esophageal until we find the lymph node. black one is a lymph node. Then we try to find the posterior vector trunk. Okay. Here we find the celiac branch. We dissect it and protect it, and we also find the gastric branch. Okay, this is the celiac branch. We, along the surface of the right lower diaphragm, use bipolar forceps and into the next or metal sac. Then we continue to dissect the posterior surface of this distal esophageum. Okay, we continue to dissect the right surface of the distal esophageum. The space is narrow, but the optic has its advantage to do this, to deal with this. So we can find the anterior vector trunk and its branch, hepatic branch and gastric branch. So we protect it, don't damage it. Here we fetch of the celiac branch, protect it, and use laparoscopic vascular staple to transect the left gastric blood vessel together. Okay, we can see the celiac branch was protected. Then we continue to dissect the surface of the distal esophageum, the posterior surface and some right surface. We also put a small gauze around the operation area. It is different from open operation. So when we needed the gauze, we can get it quickly. We continue to do some anterior surface. Okay, we use the bipolar forceps to completely dissect the distal esophageum. And I use a blood stream to drain the esophageum to the right, so to the left, so the right have enough space to make operation. Okay. In the end, we use the local cut tube to move the spleen. Because the spleen is very big, if we want to move it, we use to enlarge the insule. This method not need to enlarge any insule, can move the big spleen, so the patient can have less pain. No, we use one stem to hold the operation area. The temperature is about 38 degrees. We wash operation area from right to left, from above to below. If we find the bleeding, we use bipolar. If the waste saline is clear, it means there are no bleeding. So we can close the operation and put the drainage tube. Okay, we see the PPE again. Okay, thank you. This is the intraoperative post-operative data. The operation time is 150 minutes. Each operative blood loss is about 50 milliliters. The autologous blood transfusion was performed. On the post-operative day 7, ultrasound showed the left pleural effusion was 18 minutes without ascites, discharged on post-operative day 8. This is the picture showing the intraoperative synchronous endoscopic ligament ligation. We can see this is the endoscopy physician. He worked together with us. And this picture shows the optic splenectomy procedure. You have seen, so I don't say more. Okay, this is the vacuum lobe guide protect procedure. We can see the posterior vacuolar trunk and its branch, gastric branch, and celiac branch. Here we can see the anterior vacuolar trunk and his branch, hepatic branch, and the gastric branch. Okay, this is the post-operative feedback. After the first month, the patient had a good appetite, no sense of the fullness after meal, no diabetes, low bleeding, no gastric irritation. The diabetes of esophageal varices is short from 14 mm to 6 mm. The first The first case and second case showed the patient accept traditional operation methods, so the patient suffered from after operation suffered from the gastric irritation. The case 3, case 4 don't suffer from the gastric irritation because he accept our new technique. This is the things we can see from eye. There are still some things we can't see from eye, but this they are benefit for the patient accept our new technique. This is the right paper is showed our published paper about this clinic, this technique. The comments showed congratulations for your efforts in sharing your expertise. Definitely, you have a great experience in this technology, and it is important to share it with all community. So today I share with you. We also find a lot of meaning findings. We use 10 years follow-up data, including 519 patients. This research find splenectomy and ethical port dissection decreased the risk of HCC for cirrhosis patient with port hypertension, compared with patient only accept the endoscopy ligation. The left picture showed the incident diet of the HCC. The patient accepted the laparoscopic operation showed low incident diet of HCC. The right picture showed the proportion of occurrence of HCC. Also showed the patient accepted the operation only showed the 4.9% patient suffer from the HCC, but the patient only accept the endoscopic ligament, the patient will suffer from 11.2% suffer from the HCC. Okay, the two pictures with different static methods also show the patient accepted the operation will have a good, better survival. Then that patient accepted the endoscopy navigation. So thank you very much.
Thank you so much. You can take the seat there as you wait for the panel discussion. The next presenter is going to be Dr. Fred Liza. Dr. Fred Liza, please come to the podium. He's going to be presenting a case of ileocecal intussusception mimicking rectal prolapse in a 4-month-old female infant.
Good afternoon. I'm going to share with you a case presentation of a rare presentation of ileocecal intussusception, which manifests sometimes as a rectal prolapse. In an infant of 4 months. My name is Dr. Fred Liza, a general surgeon at Mount Meru Regional Reference to Arusha. So, from introduction, as all we know that intussusception is a common surgical condition for infant aged from 3 to 6 months. And it is a telescoping of a section of intestine. And this is it is rarely present as a rectal prolapse. As we know, most of the intussusception can be ileocecal, chronic. We have a lot of different types, but the commonest one is ileocecal intussusception. And in the mostly presentation, we have this abdominal pain for the infant or children, vomiting, and the blood stool, what we call it tarry stool. Those are the classic trial for most of the patients. The etiology of intussusceptions, as all we know, that is most of it is idiopathic, but some literature do relate it with rotaviral infection. And the management of this intussusception, it depends on the patient presentation. But generally it can be either surgical or non-surgical. Non-surgical modalities, most of the time it can be this static enema or saline or pneumatic air. For surgical, it can be either laparoscopic approach or open method, which is laparotomy. Based on our case, she was a 4-month-old female child, presented with 5 days of non-projectile vomiting, 3 episodes of food content vomitants per day, which was aggravated by feeding. This was also associated with on and off low-grade fever and 1 episode of passing black tarry stool. She presented, the mother decided to take the child to the nearby hospital, whereby she has been diagnosed with enterocolitis. So she was given antibiotics and discharged home. And the mother reported the child was responded to be good with progress for about 3 days. But over the course of illness, the mother noted the protruding self-reducing mass, Anna, and not painful, not bleeding, and no vomiting, no abdominal distension. But this it was associated by passing a normal school. And after presenting to the hospital, the diagnosis which was rectal prolapse to nearby hospital. So they decided to refer the child at the case of rectal prolapse for further management to our hospital. Upon physical examination, the child was alert, active, not pale, not dehydrated, febrile, and the vital signs as projected were essentially normal. And the abdominal examination, the abdomen was not distended, soft, not tender, but there was a significant palpable mass on the left lower quadrant, which was mobile and non-tender. And upon the rectal examination, there was an obvious circumferential protruding mass, on strain, which was reduced spontaneously, and no any other lesion was seen. This is a picture of the child upon examination. So, on investigation, plain X-ray was performed, plain abdominal X-ray was performed, which was non-eventful. Abdominal ultrasound was also performed, which revealed a target sign. And the laboratory results, the significant point was only mild hyponatremia of 133. And the other parameters were essentially normal, with HP of 11.3. So based on the clinical presentation and investigation, the diagnosis of interception was reached, and the child was planned for emergency paratomy. And in the drug findings, it was an idiopathic interception which advanced to the anus with the edematous bowel. And the intraoperative, the milking was managed only to the level of transverse colon. Hence, right endocolectomy was done, and the transverse end-to-end anastomosis was performed. This is the drug findings. As you can see, the milking was tried to be performed. So the child was then admitted to pediatric ICU, where on the second day the child was doing well and transferred to the general ward and started feeding. On day 4, the patient was discharged home, and the follow-up on outpatient was done, and there was no any significant complication recorded. So in our discussion, interception is the commonest surgical emergence, as all we know that it's mostly affecting 3 to 6 months only infants, with estimated mortality of 9.4. The classic presentation is vomiting, abdominal pain, and passing tarry stool. But sometimes it is important to note that interception may present atypically. So as surgeons, we should be raised suspicious index wherever you find the child presenting with a rectal condition. So by conclusion, diagnosing infant with rectal complaint can be difficult even in the case where clinical signs first points a rectal collapse. So therefore, conditions like idiopathic interception on colonic should be included in differential diagnosis while dealing with these infants. Thank you.
Please take a seat there. The next presenter is Dr. Teresia Andrea. Dr. Teresia is going to talk about the assessment of 8 years results for congenital tally-face equinovirus treatment.
I'm Dr. Tresia Paruhanga. I'm a general surgeon and I'm working at St. Francis University as a senior lecturer, but I'm also working at St. Francis Hospital as a general surgeon. Currently, I have 10 publications, so in various areas in general surgery, including gastroenterology, conditions, and infectious diseases in the surgery. I'm trying to go to increase my career, but I'm still struggling. So that's all. My presentation includes orthopedic conditions, but which was done not orthopedicians, but general surgeons together with the physiotherapists. As it was mentioned before, this study was to assess the 8 years result for congenital basic virus treatment at St. Francis Referral Hospital based on consent methods. So, at introduction, what is the congenital basic virus? May be defined as fixation of the foot in adduction. It is estimated that in every 500 students, 500 births, one will have the equinovirus. In Tanzania, about 3,014 new cases are identified per year. The management is usually done by orthopedic, but as we know, orthopedic surgeons are not reliable to every area because most of them they are in cities and in higher centers. So we have to do by our own surgery to save the children's life and to modify, to increase the quality of life for the future of themselves. The condition, this condition now, the reliability of the orthopedic surgeon may lead to the neglected of congenital basic virus, especially in low, middle, and income countries where the limited resources, especially in the human personnel and the specialization, we all know that it is limited. So because of that, we have to use plan B. Because of the neglection of the condition, it leads to poor economic productivity. However, the management of transplantation equinovirus by using the consent method reduces the necessity of the orthopedic surgeon in this defect. This multidisciplinary approach, including physiotherapists and any medical cadre, provided the person he or she might have trained. The training is almost 1 day, not even a week. In the consent method, there are 2 phases, being treatment phase, which is characterized by serial padded cast until the Pearland score is significantly low, between 1 to 0.5. We are going to see what is the Pearland score below. The second phase is characterized, is the stabilization, which included tenotomy and the foot abduction boots. This is the boots which the child will be wearing up to when the child is 5 years. After 5 years, the child will be weaned, will be excluded, or will be discharged from this kind of abduction boots. The Pearland score is a directive tool in the consent method treatment of the congenital equinovirus. Here we have the general appearance of the Pearland score, how the highest score is and what is the lowest. In the Pearland score, we have to divide the foot into 2 different portions. We have the hind foot, Then we have the midfoot, and we have the, what is it? We have the midfoot, we have the hind foot, and the digit equinus. In the hind foot, there are parameters where areas we showed you to measure. The highest I said is 1. For example, you can see this is a curved or adapted foot in medium. But we consider this one as the maximum by taking the measurements, where the minimum is 0, then the highest is 0. Because of these three points, each area should be the maximum score is 3, while the minimum score is 0. So because of this one, we say that we have 3 points. We have deep posterior curve creases, which is this one. Then we have the empty heel. Empty heel means that we all know that the heel is made of the calcaneum. But if the foot is normal, the calcaneum should be palpated. But in equinovarus now, the calcaneum is shifted in mid, that it is padded by the muscles. No, now because of this one now, the heel is almost empty. Now we call it empty heel. When we have the empty heel, the maximum score will be 1. But if the heel is palpable, the maximum score is the minimum score is 0. Then we have equinus. Equinus means that the rigid flexion. In the midfoot now again we have curved lateral border, which is this one. We have to measure this one in order to compare the proper alignment of the anatomical alignment of the medial curve. Now we have the lateral head of the talus. We have to palpate the talus. Is it palpable or it is not palpable? If it is not palpable, means that it is shifting anyway, or it is padded with the muscle, as we saw in the posterior, in the posterior heel, or the palpable of the calcaneum. Again, in the medial creases, if it is significantly curved, there will be like this one. That you see that the maximum score is this one, while the minimum score is 0. So these parameters now are the tool which direct someone who is collecting the clubfoot to have which severity is there. Can it be mild, can it be moderate, can it be severe. The mild is 3 by the highest. The mild can be 3 or 1 or 0.5 depending on the parent score, while the maximum score is 6. Now, the objective of this study was to assess the reliability of parent score in the absence of orthopedic surgeon, based on non-orthopedic surgeon. In the absence of orthopedic surgeon, but who can do this one? Is it necessary to be orthopedic surgeon, or anyone can do this kind of management? So the methodology was prospective study, which was hospital-based, and the patient who met the criteria, inclusion criteria, including the adherence of the clinics, were included in this study. The parent score of all of it were determined attending to the child at the first time, initial manifestation, manipulation. Why the score of this parent was continually or repetitively in each clinic to determine when the second phase should be done. Here we have the images. This is one of the examples. The child who was almost 3 weeks at the first attendance, which parent score of 60, and this is that at the age of 2 years, whereby almost it was fully collected. And here we have another child on the daily clinic activities. So what was the result? The total of 155 children were attended, but among those 60 were excluded because of other factors. Because of that, now 151 were included in this study, whereby 99 were the males and then 52 were females, making here a male to female ratio to be 3.1. The parent score at the presentation, the maximum was 60 and the minimum was 0.5. All candidates who were with the Clubfoot were treated primarily with the parallel cast as the treatment phase, and some of them were put into second phase, while the criteria of going into the second phase was the severity of the highest score, the minimum score of 0.1 to 1 were treated by basing on the treatment phase. The stabilization phase were not done the lowest period score. The Clubfoot collection achievement was 92.53. The current rate was 4.64, while the failure rate was 7.7%. The risk for treatment failure was, where non-adherence to clinical follow-up, while among those one, the working distance from the area, from the residence, was another major risk factor, called 65 and 68.5% were coming from far away, such that it was difficult to adhere to the clinical follow-up. The presence of multiple malformation were another risk, but which not so much like the walking distance. The degree of parent score was not associated with the poor outcome. So what is the conclusion? The study resulted indicated that the positive technique is a safe and effective method for management of congenital type The positive method has the advantage. Why? Can it be done anywhere, including out clinic, not necessarily to have sophisticated theater, but it does not need specialization. What you need is a physiotherapist and someone who was trained because of on that technique. This can be done anywhere. We said that is one of the risk factor was walking distance. In order to reduce this one, we can include other people, medical personnel, to achieve this, to enhance this kind of the management plan. But which only we need is just to advance our health system such that most of the children may not end up into permanent disability. Thank you. I think that.
Thank you so much for such an amazing presentation. Now we're going to take a few questions as the next presenters prepare themselves. The next session is going to be a very interesting one, again about transplant services in Tanzania. So if you have any questions to the presenters, Dr. Teresa, please come in front. Any questions?
Thank you very much for all presenters. My name is Dr. Peter, surgeon from Dodoma Hospital. I would like just to ask the second presenter. He presented the issues of dissociation. Can you just tell us the outcome, postoperative outcome and the place we're coming from? Because in our place, we have significant mortality for most children once we have done surgery.
Is there another question if we have? Oh. For Professor John, thank you for a very nice presentation from all of you, sorry. The capacity of the hospital you're working at now, is it possible to perform that procedure that is yours, that procedure that you talked about? It's possible? Even to make sure that we do not increase an incision?
I can do with laparoscopic.
One last one.
Thank you very much. I had two questions. First, to the first presenter. I was just curious to see if you do a robotic assisted laparoscopic splenectomy. It seems you go to a very long path. I didn't understand why you have to go to that extent of identifying the vagus nerve, because and take it as a guidance to splenectomy. If you are to do it open, I mean, you go direct to the splenic vessels, ligate them and take them out. Probably you can enlighten us on that. The second, I would like to commend Dr. Liza for the presentation of the interception. Is among the commonest causes of pediatric surgical cases. And maybe just to the audience, what he has presented was an advanced stage of interception. And commonly we teach our young surgeons how to differentiate between rectal prolapse and the prolapse with interceptum. Just putting your finger to insinuate around the mass to be able to differentiate the two. But fortunately, the baby had a very healthy bowel with such an advanced interception. So it was really a lucky baby. Thank you.
Okay, thank you for positive comments. I'm going to respond on the questions from Dr. Mary, asking about the outcome. Basically, the general outcome of interception is the mortality is about 9.4%, but on our settings, the mortality is even higher, and the cause of that mortality is delayed. Most of the time we see diagnosis sometimes leaders or the kids delayed to come to the hospital. So by the time the child arrives, it's already too late. So that's generally our setting actually the mortality is even higher from that of 9.4.
Okay. Thank you for two questions. Dr. Lucia asked whether we can do the operation use open operation. Yes. I also can perform the operation with laparoscopic. The second question, I think laparoscopic operation not need a big incision. And the laparoscopic enlarges the view 10 times, from 5 to 10 times, so we easy to find the regular locus. When we open, not easy to find it. When the laparoscopic not need a big operation, so patient with the less pain, so he can recover quickly, and after the operation, the first day he can walk, and his gastric intestinal function can recover quickly with the less pain. The pain can cause many different effects about gastroinfector and other nervous system reflux. So we prefer to choose local or laparoscopic operation to do operation, so people can recover quickly, and we can easily to find the liver, because the liver is enlarged from 5 to times, so we can get it faster and easily. When operation, we don't have a good view. Just like I have showed the screen. We can, when we do operation, open operation, maybe the only one doctor can see the operation area. But we use robotic or laparoscopic. All the patient, all the doctor or all the assistant can see the operation procedure and can make the operation smoothly. Thank you.
Thank you so much to our 3 speakers. They'll be around, you can catch them up during lunch or tomorrow, and if you have any further questions, I'm sure they're happy to hear you out. For the sake of time, we have to move to the next session. Let's give a round of applause to our speakers. Thank you very much. As you're preparing for the next session, just a reminder that this conference is live. It is live under the sponsorship of Global Medicare. So there's a link that has been shared in the TSA group. You can share that link with our colleagues who have not been able to attend here so that they can follow the conference live. I'm going to hand this over to Professor Popo, who is going to moderate the next session.
Yeah, good afternoon, colleagues. It's my pleasure to moderate one of our most recent advances in surgical practice, and that is transplant. And I'm going to have 4 wonderful colleagues. One is my old friend and classmate, both in undergraduate and then ahead of me, postgraduate Professor Mushamba, who is leading transplant services from Dodoma, having trained from trained by Japanese transplant surgeons. One of the most robust and regular transplant services focusing on the kidney in the country. And the other 3 presenters are also my colleagues that we have worked with in various efforts in vascular surgery. And now we are advancing into transplant surgery, especially the surgical education aspect of it, from the University of California, San Francisco. And the oldest of them is Peter Stock, who will talk with us about the transplant in HIV positive cases. He's one of the most experienced in that area, and is accompanied by his student, who is also a very good friend, Professor Sharif Said. I was trying to find whether it is Said or Said. It's Said with S-A-Y-E-D. Both of them are abdominal transplant surgeons. They do both kidney, liver, and doctor's pancreas. And if opportunity allows, they do intestines. And I don't know what else they will transplant in the abdomen. And they are coming with Stephanie Lin, who is also a very good friend that we have started together our vascular training. She has visited us, this being the 4th time. And she has experience in staying in Kariakoo, in the middle of busy Kariakoo, and going to the airport on a tuk-tuk, only to realize that the tricycles cannot enter the airport. She was here to carry out the luggages from Tugu Road to the terminals. And she has trained most of us in every fistula. So I'll give them this podium, and Professor Mushamba will start by telling us about transplant services in Tanzania, especially from Dodoma, an overview. It's not structured. And then the 3 will come in the order that I will decide. And then the floor will be open for us to jump into questions. Professor Michelle, you're welcome.
Good afternoon, everybody. Fortunately, I had the PowerPoints for presentation. Otherwise, I was not prepared to present. Okay, but I think what I have is adequate for you to follow what we are doing in Dodoma. Okay, so kidney transplant in Dodoma and our experience. How do you do this? It doesn't count. So we all know that. By the way, this is very important infrastructure if we have to start kidney transplant. Okay, it's especially ring retractor, abdominal retractor, very nice for kidney transplant. And if you are to start, you must have this for you to be comfortable. Have you ever celebrated seeing BELIVE? Okay, if no, then your kidneys are functioning. Okay, I tell you, the moment you have no urine, when it comes back, you're going to celebrate. So it is the transplant surgeon who celebrates when they see first urine. Okay, most of you won't because your kidneys are properly functioning. Okay, so CKD, kidney failure is a spectrum of kidney dysfunction. Okay, and it is assessed in two ways. One is to see how much albumin is there in your urine, and then the other one is to estimate the glomerular filtration rate. Both are important. Okay, as you can see, when you have urinary albumin that is in excess of 300, you are already in trouble. Even when the estimated glomerular filtration appears almost normal, you are already in this gap. Okay? But equally, when the estimated glomerular filtration rate is less than 15, it doesn't matter whether you have urinary albumin or not, you're already in trouble. Okay? So the message from this definition is that you must always check your urinary albumin, and especially so if you have reasons if you are in a high risk group, for those who are diabetic, hypertensive, okay, and including those who are aged. Okay, you must always check urinary albumin. Okay, so that definition is there, and you can actually access it. Okay, so we know diabetes, hypertension, age, and of course glomerulonephritis are the top commonest causes of CKD everywhere. Okay, it doesn't matter whether in developing countries or developed countries. And in our series, in excess of 85% of cases are due to hypertension and diabetes mellitus. Okay, so these are the top levels in terms of kidney function. Okay, and of course we know when you have CKD and you already have heart problem, you may die earlier than in normal individuals. Okay, so how big is the problem? Seriously, CKD is commoner actually than diabetes mellitus. Okay, it is commoner than all the cancers worldwide. Okay, actually 20 times. Okay, and it is even commoner, 20 times than individuals who have HIV, who are on treatment, and those who don't. Okay, and twice as much as those of TB. In other words, almost 1 billion persons have CKD. So that is a big problem, isn't it? Okay, and the color that you see here is generated from artificial intelligence. How big does a billion persons look like? Okay, so each blue dot here has 10 million persons with CKD, and that is how big the problem is. The prevalence around 10%. This is from the International Society of Nephrology. Okay, but also look at the disability adjusted years, life years here. 491 for each 100,000 populations. That is quite significant. Approximately 41 million persons are on dialysis. Okay, so although the prevalence appears normal, if you look in the global prevalence, it seems the prevalence in Africa is around 4%. But these people, okay, Cousin Etaro and colleagues, estimated that we are not even behind. Maybe we are not actually seeing all the patients with CKD. Okay, and we said earlier, 1 in 3 cases, okay, persons with diabetes will be having CKD, and 1 in 5 are those who are diabetic or have hypertension. Okay, so CKD is a big problem. Okay, and this is what we discussed earlier. Even in terms of mortality, CKD causes a lot of deaths. Okay, 2.4 of all the deaths are due to CKD. Okay, and that number is quite big, 1.4 million each year. Okay, and of course we know, as you can see, this is the global prevalence of causes of death. Ischemic heart disease tops, okay, in all the countries worldwide, and that is followed by stroke, which I think these two have the same risk factors. Okay, and you may not, you can see kidney diseases, it is there, but if you follow the trend, okay, maybe if you do, because these data are from 2019, if you do today, maybe CKD will be around this area. Okay, you can also see the trends here, causes of death. Okay, 2000 it was here, okay, and now it is there, so there's an increment here. And the risk factors for ischemic heart disease and stroke are the same risk factors for kidney disease. Of course, in Africa, the commonest cause of death, of course, will be infection, as you can see, neonatal sepsis, lower respiratory tract infection, etc., etc. Okay, but CKD causes a lot of death. That is the message from that presentation, from that slide. Okay, spending 2 is quite huge. You can multiply. Okay, so globally in the US, for example, for each person the government uses $353. Okay, you can multiply that by the number of persons in the US. Okay, but globally 216. So that means including Tanzania should be at around 216 for each person. Okay, and you can multiply that by almost 70 million persons that we have, and then see how expensive that one is. And maybe that is why NHF is dysfunctional. Okay, but don't quote me. Okay, spending is quite significant. Okay, but remember, we were talking about CKD, but there is acute kidney injury. Okay, and the prevalence globally, 7 to 18% of all admitted cases, including MNH. Okay, but the question is, how many times do we often check kidneys for kidney function in our patients? Okay, if we don't frequently do that, then one of the messages today is make sure, including those that have done laparotomies, you have always check kidney function. I think at UDOM is around 20% of the laparotomies, emergency laparotomies, have acute kidney injuries. Okay, and of course, the other problem is that majority of the almost 90% of the cases of acute kidney injury who passes away are in developing countries, unfortunately. Okay, maybe lost the opportunity to treatment, but also availability of resources. Okay, renal replacement therapy is the way of treatment of CKD. Okay, and the maps that you see here is telling you the prevalence and the incidences of these renal replacement therapies. Okay, chronic dialysis, Tanzania is there, so we have already started there. Okay, this is incidence of kidney disease, and Tanzania is there, so we have already started. Okay, but we don't do very much on peritoneal dialysis, so the data is missing. Okay, we are not seeing global. Okay, so there are three modalities, as you can see. I'm not willing to teach you on this. KT at University of Dodoma, BMH. Okay, remember that BMH is the brainchild of UDOM. Okay, BMH is born, just like Godzilla was born out of MUHAS, BMH too was born out of University of Dodoma. Okay, so, and we do this project together. Okay, so KT is an exit. I presented there. Okay, and if you do KT, of course, you improve quality of life, you increase survival of the patients, of course, including the costs that are related to hemodialysis, significantly reduced when the patients undergo KT. One of the most important thing in kidney transplant is that you can't do kidney transplant alone. Okay, just like you open the heart, you can't open the heart alone. You need a team, and a team that is motivated and well cohesive, okay, in which the environment within the team is conducive to allow kidney transplant. Okay, these are the institutions that we have collaborated. Okay, and I'm going to narrate Tokyo Women Medical University and Tokyo Medical Group. Okay, Tokyo Medical Group is one of the largest medical corporations in the world. I think third largest according to the data that is available. Okay, I'm going to talk a little bit about that. Okay, but Tokyo Women Medical University is one of the pioneers of kidney transplant, and especially living donor, okay, ABO incompatible cases, they have done a lot. And one of the professors who was doing procedures in this hospital, okay, came to help us to initiate kidney transplant. Okay, so the story of KT started with these two men. You know this man, and maybe you don't know about this man. Okay, he is this man has amyotrophic lateral sclerosis. He can't walk. Okay, he's being helped in every manner. But of course, he had a good brain that he initiated the Tokyo Medical Group, which I said is the third largest medical corporation in the world. Okay, they have over 70 big hospitals, okay, 288 clinics. Okay, so when they met, they signed a memorandum of understanding, okay, between the Ministry of Health, okay, and the Tokyo Medical Group. And of course, the first hospital should have been built, I think, at the within the University of Dar es Salaam campus, but things did not work, and it only came to light again when Benjamin Mkapa became the Chancellor of the University of Dodoma. Okay, so these two are the ones that initiated the relationship that led to donation of 10 dialysis machines in Dodoma, UDOM Health Center, and thereafter the initiation of kidney transplants in Dodoma. Okay, so, and there are a lot of persons to mention. Okay, I'm not going to do that, but one of the key persons is Professor Kobayashi, who was quite strong on us to make sure that the kidney transplants started in Dodoma. Okay, and this is Dr. Chandika when he was announcing the first kidney transplant in 2018. Okay, so we have a lot of colleagues, as I said earlier. I am not going to mention all of them because they are numerous. Okay, but this is Professor Tanande, one of the renowned kidney transplant, and he has 3 patents with over 400 papers. He is a very nice, very good surgeon to work with. Okay, and our team, of course, it includes everybody in the hospital. Okay, so if you wish to have money, don't team up with kidney transplant because you won't get money. There's no money. Because the team is so much big that you cannot distribute yourself the money that you get adequately to serve yourself. Okay, so a lot of people are actually supposed to be within the team. And then you have to maintain the teamwork all the time. Okay, so what you see here is after 11 cases of joint KT with Japanese, this was our first kidney transplant that we did ourselves. Okay, the secrets, I think, I understand that the Uganda Medical Center are going to start kidney transplant very soon. Okay, so these are some of the hints if you are wishing to have a successful kidney transplant. Okay, big team, good coordination. You must be passionate. Okay, you must be continuously learning. Okay, and of course, sometimes you need to go ready. End of summer before you start kidney transplant. That is some of the secrets that led us to begin kidney transplant very early on, before even MONH had done so. Okay. There's a story here, maybe I should tell. This lady is a nephrologist from Japan, and instead of celebrating the first urine, she was crying. Okay, so again, first urine can make you cry or can make you celebrate. It depends on your emotions of the day. Okay, and she was being comforted by this surgeon from the Tokushika group. Okay, so the humanity should be the purpose of kidney transplant, and that is what we are doing. One of the things that you can see after 4 weeks of KT, these people regain their health and they are quite healthy and active in the society. Okay, and he is one of he was a public relations officer at BMH with the CKD, possible hypertension with no obstacles. But we saw how he was before kidney transplant, and this is how he looked after kidney transplant. He's a very happy man, and actually has been shifted from BMH to another parts of the government, and he is working. Okay, you unite families, because usually for you to access dialysis, some people have to leave their homes to come in town for hemodialysis. Okay, so we unite our families. Okay, and of course, hope. Our patients that we have seen. Okay, so the data that you may see here is 36, but actually at BMH we have done 40 cases. Okay, and male to female ratio you can see there is the same. There are 4 additional cases that are not in this data. Okay, and the other characteristics, as you can see. Okay, it makes a lot of sense that most of these people are employed, which means it does not mean that they are more frequent, but I think maybe they have the means, financial means, to initiate kidney transplant than the other persons. Okay, and maybe we are not even seeing visits. We have seen some students here. Okay, and that is why the other group is having 9 cases. Okay, education I think is not very important for today. We have transplanted at least one non-Tanzanian person. He was a Congolese who came and we did the kidney transplant. He's very happy in Lubumbashi. Okay, and see the causes: hypertension, diabetes. Okay, in most of the cases. Okay, of course, even when you say glomerulonephritis is not histological diagnosis, it's clinical diagnosis. Okay, use of catheters. Ideally, when you go for KT, you have to have either permanent or AVIF. Okay, because temporary catheters could risk your cases to significant infection, but at least 10 of them had temporary catheters. Okay, one of the cases had 3 arteries, the others 2. Okay, and one, majority of them had 1 main renal artery. Okay, which is quite significant. I think in most of the studies that we have seen are usually single renal artery. Okay, mini age 43. We have done transplant to up to 60 plus, but the experience is not very nice for us. Okay, maybe because we use a lot of time, we spend a lot of time on KT, sometimes to 6-7 hours. Okay, so so far, if you are above 60, we don't like to run into kidney transplant. Okay, because the risk, anesthetic and surgical risk are quite high in these patients. Okay, and forget about the incompatible case, because that was mistyping when we were entering data into SPSS. Okay, but note that 8 cases of the donors were from spouses. Okay, which I think, are you taking spouses?
The laws of the country.
we have done at least 8 cases. We don't have any law that's guiding or prohibiting us to use that. Okay, but we know that the district is under to use even cadaveric kidney transplant. Okay, but of the 8, all of the 8 were women donating to their husbands. We haven't seen any husband donating to their wives. So if you think you might get CKD, you better marry somebody who is compatible with it. Okay? Maybe that is not important. It is a cultural issue. Okay, and the other issue is that we have done quite of significant high-risk cases. You can see we look at the PRA, pan-reactive antibodies, whether they are TSA positive, okay, and the degree of mismatch, and then we stratify the patients into the risks that we have said there. But you can see that we have done intermediate and high risk to a significant number of cases. One of the advantages that we have is that we can do plasma exchange at UDOM, okay, at BMH. Here, I think the most important thing here is not even surgical site infection in 2 cases, but dehiscence, okay? Steroid dehiscence. When you operate fatty individuals and they use high dose of methylprednisolone steroids, and then there are immunosuppressants. Sometimes you have no infection, but the fat does not break up, and then you have a breakup of the wound, but there's no evidence that there is infection. Okay, and the first 2 cases had prolonged Friedreich lymphoria. Okay, one of them was actually the first case that we did. Possibly we forgot to ligate the lymphatic vessels. Okay, we have lost at least 3, including these 2. We have lost at least 3 kidneys. Okay, and lost 1 patient. Okay, in hospital. Okay, the first 2 kidneys, I can tell you, was due to skills mix. We had received one of the surgeons from another country with maybe different kind of teachings on how to handle vessels. And now because he was new and exotic, we possibly thought he knew better than ourselves. Okay, I can tell you that is the reason for the first 2 kidney loss. Okay. And the third one may be thrombotic events. The third one. Okay? And we have lost actually 4 cases. You can see there, 2 of them corona-related death. Okay, one of them rejection and then thereafter infection, and she died when she was in the CCBRT. Okay, and one of the cases is the one that I said in hospital death. Okay, in March we lost one of the recipients, actually within 12 hours after kidney transplant, maybe anesthetic complication. So in terms of death, we can attribute at least one to rejection, maybe even this thrombotic event could be also be due to rejection. Okay? But the other two died because of other causes than transplant. Okay, and this is one of the kidney that I said it had thrombus. You can see huge thrombus here, and the vessels were quite thrombotic, almost occluded. This was removed in the fifth day after kidney transplant. Okay. So we presented this case in Mbeya, if you remember. This is one of the high-risk cases, surgical high-risk case. This woman had all these conditions. Okay, and one of the reasons why we operated her is because she had lumbar fusion, and it was very, very difficult for her to kind of do hemodialysis on the sitting and lying position. Okay, and of course she had a polycystic kidney disease, as you can see, huge polycystic kidneys. Okay, which, if you know, it also obliterates the site for kidney transplant. So we had a lot of discussion, and she was 64, by the way, diabetic and all the things that you see there. We had a lot of debate whether we should do, okay, because she was rejected, and she was rejected from MOH, she was rejected in South Africa, she was rejected in India, and rejected in Dubai. But then she had a message of hope from the Dodoma, the new beginners, high risk thing. So after debate, we said, if we remove, we had to do both donor polycystic kidney nephrectomy and kidney transplant at the same time. But then we had an algorithm that if we do remove the polycystic kidney on the site that we're going to transplant, if we do that within 45 to 1 hour, then we can proceed to kidney transplant. Okay, and we did that within 50 minutes, and then we proceeded to kidney transplant. And of course, she got a cardiac arrest immediately after recovery, but that was dealt with. Okay, and now she's very healthy, and she is in which country again? Because she can because Saudi Arabia, she's very happy. Okay. By the way, her family is in Morogoro, so I hope maybe we can connect with them to buy us some beer. And this was the immediate results, and this was the third day. Okay, and this was the polycystic kidney that we removed. Remember steroid dehiscence of wounds in your obese patients? Yeah, she got one. Okay, but otherwise, that was a success, and she's quite happy now, no longer on hemodialysis. I think these other information are not necessary for you. Okay, maybe for us. Continue. One of the questions that we should ask ourselves is why MOH has never invited BMH in their transplant. That is one question. And then question B, why has BMH never invited MOH to come and learn? Because they have learned from India, we have learned from Japan. So maybe a kind of coalescence of these skills would make Tanzanian skills. So, Chief Mtaturu, next time you have kidney transplant, kindly please invite me and my team. Okay? And then the hospital will take care of our DMs. Okay. Of course, the most important challenge here is the availability of donor, and I have said that the legislature is underway, and when that is done, we shall have an access to deceased donor donation, which I think is going to improve a lot the availability of kidneys. Thank you.
Thank you, Professor Mshaba, for the presentation. I was tempted to say, when I was talking, but since he began by saying he did not want to present, then I said I should also refrain from provoking him. But otherwise, thank you so much. So, Stephanie will upload on the next presentations, and Said is going to present first.
I can just use the morning, everyone. My name is Sharif Syed. I'm an abdominal transplant surgeon from UCSF. It's our distinct honor to present to you all about some of our thoughts about the next chapter of end-stage kidney disease care in Tanzania. So I just wanted to share a little bit about what brought us here and why are we here, or who brought us here, specifically the opportunities that we've seen and directions for expansion, much of which were covered by Dr. Mshaba already. So it was fate. Essentially, Dr. Akoko, Dr. Mwanga were visiting San Francisco on a separate surgical education visit. And through a very convoluted chain of emails, we got an email about a young child in Arusha who has HIV and is living in a care home, who developed end-stage kidney disease rapidly at the end of last year and had been on dialysis. And the call to us was, is there anything that we can do to help this child? And so there had been a few Zoom calls, and it was a very emotive and energizing story about this young child. And we discussed it with our colleagues, our Tanzanian colleagues, who sort of encouraged us to come and check things out and see what could be offered to this child. We had a relatively last-minute trip booked, and we had the privilege of going to visit the home in Arusha. The home in Arusha is run by this incredible woman called Emmy, who's a nurse, who has cared for over several hundred children in her care home, specifically for children with mental disabilities, children with other disabilities, children with who are vulnerable, and orphans. And she has dedicated her whole life to not only caring for them, but building a whole educational infrastructure around the home to educate these children to prepare them for their life. And so we came to visit our patient, patient N, who's a sweet 13-year-old child who developed acute kidney injury in the end of last year, in November, and progressed quickly to chronic kidney disease, and then initiated dialysis via a temporary dialysis line at the end of last year, December 2023. And she's been requiring dialysis 3 times a week at a local hospital in Arusha. Comorbidities. Number 1, HIV infection. So she had a vertical transmission from her mother, and the cause of her AKI is still unknown, but thought to have been either secondary to her HIV or due to medications that her mother was giving her, adult doses of HIV medications that could have led to some significant kidney injury. But in all honesty, we don't have a clear understanding of what led to her end-stage kidney disease. The second issue is one of malnutrition. She was malnourished, requiring significant nutritional repletion, which was compounded by the fact that the dialysis that she's receiving may be from adult disposables in the dialysis machine, which is leading to further protein losses. So, complications from having a temporary dialysis line. She unfortunately, 2 weeks ago, developed line sepsis and was fevering and extremely unwell and was transferred to Dar es Salaam, where her line was removed and she had 2 weeks of blood antibiotics IV and got better, had a other secondary temporary line placed, was aggressively dialyzed on a daily basis, and then had a permanent catheter placed finally before being transferred back to her home. And so the only thing on exam is that she's of short stature, but she has significant ascites still from protein malnutrition and an umbilical hernia, and appears quite unwell. Her labs are hyperalbuminemic. She's HIV positive, but without a detectable viral load. And her echo showed signs of fluid overload with a reduced ejection fraction. So what's complicated about this case for a country who has built an incredible infrastructure for kidney transplant that is looking to get to those next levels of care provision? Pediatrics. So dialysis access for pediatric patients is challenging. And there are specific challenges when it comes to kidney transplant in pediatric patients that need to be considered. Malnutrition on top of that, and the challenges of nourishing a patient with electrolyte abnormalities and fluid restrictions. And dialysis in pediatric patients is a specific issue, especially when considering peritoneal dialysis versus hemodialysis. And then the third complexity, which is obvious, is her HIV infection. The immune dysregulation that occurs with HIV, opportunistic infections that could be faced in the post-operative period, and medication interactions with her HIV infection control and immunosuppression are three clear complexities that we identified. The other complexity is living donation is the only mechanism of kidney transplant in Tanzania at this time. And her mother is also vulnerable, has other children that she's responsible for, and the child is obviously living in a care home. She herself is obese and has risk factors for diabetes and is HIV positive. And when evaluating donors, we always have to keep the donor safety as the paramount issue. As much as we care for the child, the donor safety is paramount. And so these lifelong risks for her herself to develop kidney disease is slightly concerning and something that we will need to consider further. And so, what has patient N taught us about the next levels of kidney transplantation in Tanzania? Dialysis access and complications. We'll talk more about that. Kidney transplant and the care for immunosuppression in pediatric patients. Differences in technical care, differences in medical care. Nephrology practices, disposables, dialysis machines that could be improved upon. And then organ availability. Deceased donation, and Dr. Mashangwa spoke about local legislature regarding brain death that's in the works at this moment. and kidney transplant in HIV patients. So I just wanted to set the scene for what brought us here, and then I'll hand over to my colleague, Dr. Stephanie Lin, who will speak more about dialysis access, and then we'll end off with my mentor, Dr. Stock, who will speak about HIV in kidney transplant.
Good afternoon. So I'm going to briefly speak about CKD in the pediatric population. And one of the key factors in terms of this is that oftentimes diagnosis is quite delayed. And that's partly due to general inexperience with pediatrics, and oftentimes, particularly in these areas, confusion with malnutrition. Patients present with ascites, but thinking that it's more related to malnutrition rather than some sort of nephrotic syndrome that can often delay diagnosis, which then leads these patients to present with severe disease, much like me did. The risk factors for developing CKD in the pediatric population include preterm birth, low birth weight, and a small gestational age. All three things are quite common here in Africa. And then in terms of the causes of AKI in low-middle income countries, it's quite different from what you would find in high-income countries, where most instances of AKI occur in patients who are hospitalized. In low-middle income countries, the incidence typically occurs as a result of acute diarrheal disease, sepsis, hypertension, malaria, other very much more unusual causes. And I think the takeaway message here is that at least 10% of those patients with AKI go on to develop CKD. So causes of CKD in low-middle income countries, typically, like I said, mentioned AKI, congenital anomalies, nephropathies, infectious diseases, which then progress to chronic glomerulonephritis, and then in Nima's case, perhaps adverse medication effects. Other considerations for CKD in the pediatric population is that it affects more than just the patient. It creates a significant familial financial hardship and leads to disability-adjusted life years lost, like Dr. Mashamba mentioned, both of the patient, if not in Nima's case obviously, but also of the family who have to take time off from work to care for her. The reality is that mortality without dialysis is nearly 100%. Even with dialysis, mortality is still very high, 46%, and renal recovery typically only occurs in 10%. So that means we have to consider how to manage pediatric end-stage renal disease. In general, most of these patients are chronically under-dialyzed for various reasons that Dr. Saeed mentioned, but because they're under-dialyzed, that leads them to be at risk for higher rates of infection, other morbid effects, and poorer quality of life. Death or discontinuation of treatment occurs in 50 to 80% of children. And as a result, end-stage renal disease ends up being the fifth most common cause of non-communicable disease death globally in those patients who are younger than 30. Although more than half of children live in low-middle income countries, maintenance dialysis options and accessibility is quite limited. And basically what that means is that the long-term survival and quality of life of these kids depends entirely on being able to be transplanted, just like with Nima. So our goal in thinking about dialysis access options is to try and optimize the patient's health for eventual kidney transplant. So dialysis access as a bridge to transplant, the KDOQI guidelines recommend that permanent access be considered in all children over 20 kilograms if transplant is not expected to occur imminently, and what imminently broadly defined is within the next 6 to 12 months. In the US, you can see that the management of pediatric end-stage renal disease for the very young is predominantly done by peritoneal dialysis, which my understanding is not readily available here. As the children get older, that shifts between PV and then converts a little bit more to hemodialysis and then first transplant. Pediatric access options include peritoneal dialysis, as I mentioned, which is the preferred mode in many countries. In general, PD is much less disruptive psychosocially for the patient and their families because it is home-based, and there's no size restriction on it. You can basically do peritoneal dialysis on any child of any size or age. For hemodialysis, arteriovenous fistula or graft, if necessary, is preferred if you're going to do hemodialysis if the patient is more than 20 kilos. Hemodialysis does result in better solute clearance, anemia, and volume management, as well as controlling that low albumin, like Nina has. However, it does require living in very close proximity to the dialysis unit, because oftentimes these kids do need to be dialyzed very frequently, 3 times a week, if not more. There are a few circumstances in which a tunneled central venous catheter may be acceptable for hemodialysis. Some of that is related to lack of local surgical expertise or equipment for either arteriovenous access or peritoneal dialysis. If the patient is too small for an arteriovenous fistula or graft, and if it's intended to be a temporizing measure to get them to transplant or to getting an AV fistula or a peritoneal catheter. However, interestingly enough, despite all of that, 70 to 80% of PD patients still receive dialysis through a tunneled catheter. In terms of pediatric hemodialysis, with the proper equipment, it can be done in patients as low as 2.5 kilograms. You can imagine how small that is. But you have to have the right consumables. The dialyzer does have to be appropriate for the patient's body surface area. In addition, the tunneled central venous catheters that I mentioned would typically be used for a patient this small do have relatively decent short-term 1 year and 2 year durability, so certainly much better than a temporary catheter. In instances when patients are not able to do peritoneal dialysis, for example, maybe they had necrotizing enterocolitis and their abdomen is hostile, if they've had recent abdominal surgery for some reason, or perhaps some severe respiratory disease by whatever cause, hemodialysis would definitely be the recommended option. The other reason why you would want to specifically consider PD hemodialysis would be if you do need to take off certain solutes or a large volume, in the US, comparing central venous catheters to a few technical notes on central catheter access. Typically, we want to stay on the patient's right side if possible. That is associated with fewer complications. Typically, the patients, especially pediatric patients, you may want to have them intubated so they're not going to be moving around. Shoulder roll under their their shoulders to kind of extend their neck. And then in terms of techniques, you can do percutaneous techniques down to a 2 kilogram baby. But the IJ is quite small, so in those instances you'll want to use something very, very small like a 4 French, which doesn't actually end up being tunneled. Ultrasound guidance is very helpful if you have that option. And if not, cut downs can also be done. And in the cases of babies that are very, very small, dialysis can be done with just a single lumen 2.7 French catheter. One note is that when you do have these cut downs, a lot of times the catheter may not be completely occlusive within the vein. And since these babies have very little blood volume to lose, tying off, ligating the vein peripherally actually, even though it sounds horrible to ligate a vein that's working, it can actually be safer in terms of avoiding bleeding risk. For arteriovenous access and technical notes, pre-op vein mapping does increase your chances of success. In kids, you can do access down to 2 millimeter, 1.6 millimeter size. They're super tiny, but it can work. In these small vessels, maturation does take longer, however, so it is something to consider, like I said earlier, rather than later. The vessels are quite vasospastic, so if you have access to a tourniquet, that's often better than just using clamps, vascular clamps. You can also consider interrupted stitching instead of continuous, which allows the vessel, minimizes the risk for stenosis, actually, and anastomosis. Heparin and other vasodilating agents can be used, as well as mechanical dilation, where you maybe insert a metal dilator into the vein or flush with heparin saline under some sort of pressure to try and dilate the vessel a little bit better. Surgical microscope and microvascular instruments is really important, especially if you're going to be doing somebody who's particularly small. Just to mention a peritoneal dialysis in pediatric patients, because it is the most frequently used modality worldwide and it has a long list of benefits. It is something that is preferred in infants, especially if they do have difficult vascular access or if they've had hemodynamic difficulties with hemo because of the volume shifts and their limited body fluid volume. So it is something that can also be done laparoscopically. So for those of you who have laparoscopic capabilities, this is something that is an option and is really quite ideal for laparoscopy, as the complications related to peritoneal dialysis can be fairly easily treated with additional laparoscopic procedures. In particular, omentectomy is something that's frequently recommended in order to optimize catheter function, and that's done empirically, especially if the child is less than 2 years old. And then there are certain catheter types that are favored in terms of best function and lowest risk of infection. Peritonitis is the #1 complication, and catheter dysfunction is the #2 complication. So technical factors that definitely weigh in terms of trying to reduce those risks. So in summary, in terms of dialysis access, and I think this kind of goes for adults as well as children, dialysis really is a bridge to kidney transplant in most cases. PD is the most flexible and possibly the most cost-effective mode of dialysis if it's available. AV fistula is certainly the recommended hemodialysis access over a tunneled central venous catheter for various different reasons. It can be technically challenging, particularly in kids or small adults, but it is feasible and durable, and it's primarily limited by your interest and your training and equipment availability, and that's all things that can be remedied. Non-tunneled central venous catheters do have the worst outcomes and function, so that's just a reminder to try it when you can, to either convert the patient to a tunneled catheter or have an arteriovenous fistula made. The goal really is to provide the safest, best option for the patient and to maintain their health as optimally as possible for eventual transplant.
Thank you, and thank you for inviting us into your transplant community. It's been a real privilege. I realize I'm what's keeping you from lunch, so I will be brief. When I started in 1985, I'm old, in San Francisco doing transplants, that was the cover of the national magazine, where people from HIV were progressing to AIDS and dying. Well, that has changed. That has changed dramatically from a fatal disease to a chronic disease. And the transplant community in the US was very slow to recognize that. In fact, this is a picture from our hospital, from San Francisco General Hospital. This is what people did whenever we had to operate on somebody with HIV. We put on spacesuits. People were scared. And I think as you start to transplant people with HIV, you have to provide the operating room nurses, the anesthesiologists, everybody who might get a needle stick. Happens more frequently with liver transplants than kidney transplants, but you have to provide them with easy access to immediate medication, antiretroviral therapy. That helps take away the fear of operating on people with HIV. So what has changed? The first thing is the combined antiretroviral therapy has decreased the mortality, it's decreased the incidence of opportunistic infections, and decreased the hospitalization rates. So it is no longer a fatal disease. It's evolved to a chronic disease. The other interesting thing, the immunosuppressive medications that we thought were going to be so bad for people with a theoretic diminished immune response, actually may have anti-HIV qualities. I don't have time to go into that. But I think the thing that's changed the most, not only for HIV positive recipients, but for all our recipients, is our ability to prophylax against opportunistic infections. That has totally changed the face of transplantation. When I started to do transplants in the 80s, when people got cytomegalovirus infections, it was almost always fatal. They'd be intubated and that was it, they would die. And that has evolved to an outpatient therapy. So how we prophylax the patients is so important. In the US, HIV nephropathy continues to be a problem, at least 1,000 new cases a year now. And it is, interestingly, it's the third most common cause of end-stage renal failure in people of African descent in the United States that are between the age of 20 and 60. Liver transplantation, which I'm just going to briefly allude to in this discussion, is a significant problem in people with HIV, end-stage liver disease, the life expectancy, the prevalence of hepatitis C is high. In the US, it's 30% of the patients who have HIV are co-infected with hepatitis C, 10% are co-infected with hepatitis B. Non-alcoholic steatohepatitis, or NASH, now called NASH, is an increasing problem in the US. It's almost become the most prominent reason we need to do liver transplants in the US. The other problem is people with HIV do not tolerate end-stage liver disease. They progress to cirrhosis and death fairly quickly. In the 80s, our government refused to provide the necessary support for research and for drugs, but the HIV activists in the United States got together, banded together, and really got us the support for our first national trial. And I mentioned this trial because Dr. Mashamba, you were talking about the importance of collaborating with all the teams, getting your transplant teams together. And I think it's so important in order to get the numbers that you need to do any sort of study. It's so important. And this study was spread across, it was based in San Francisco, but it was spread across the United States. And that's how we got 125 liver transplants done and 175 kidney transplants done fairly early on to make it a something that insurance companies would then fund. In the beginning, we were very, very conservative about who we would accept. We still require CD4 counts to be above 200. We dropped that to 100 for liver transplant patients because their spleens from the portal hypertension get really big and there's a lot of splenic sequestration. They have to have an undetectable viral load if they're kidney transplant patients. If they're getting a liver transplant, we allow some detectable viral load because the antiretroviral drugs can cause toxicity to the liver. But in that case, we want to make sure we can suppress the virus post-liver transplant. Here's, let me just cut to the chase with the outcomes. So for our kidney transplant patients, that top red line is the Scientific Registry of the United States. So we have a very, very rigorous registry, so we can monitor what happens in all the recipients across the country. So that red line is all kidney transplant recipients. The middle line there is the dotted line is our HIV positive recipients, and the bottom dashed blue line is our patients that are over the age of 65, and we use them as a comparator because they're considered acceptable for transplant, although they're a higher risk and a highly selected group. But you can see going out 3 years, this was our first publication, the results are essentially comparable. And this really changed the way the US thought about it. What was really interesting about this study was we thought we would have a very low incidence of rejection because you theoretically think they don't have a good immune system. Their CD4 cells aren't normal. But in fact, it was just the opposite. They have a 2 to 3-fold higher incidence of rejection. So it's not the absence of an immune system, it's the presence of a very dysregulated system. And every one of those rejection episodes takes a little bit of life out of that kidney. So we need to get a lot better at that piece of it. Now, there's a couple of reasons for the dysregulated immune system that I'm not going to get into. But if you only take one message out of this lecture, if you're going to plan a transplant in somebody with HIV, you have to get them on an antiretroviral regimen that does not have the protease inhibitors. The protease inhibitors interact with the cytochrome P450 system, so the drugs just don't get metabolized normally. So you're forced to give less drug, and that exposure, that lack of adequate exposure accounts for a lot of the rejection. In fact, if you can get patients off of the protease inhibitors onto what's called the integrase-based regimen, it's basically like managing HIV negative patient. The teams in France and Spain have beat us to the punch, and they stopped using the protease inhibitors in the transplant patients from the get-go, and in fact found their rejection rates dropped to normal. So again, if you take one message out of this lecture, it's that. And you can see, this looks at our long-term results just from our patients that were transplanted in San Francisco. Going out 15 years, if there was no rejection episode, our graft survival is around 85–90%, so quite good. But if they have a rejection episode, you can see what happens. Now, I'm just going to briefly talk about the liver transplant results. Again, just in the patients that we transplanted in San Francisco, we compared our HIV positive patients and used propensity matching to 440 HIV negative recipients, so we could see, provide the right data to insurance providers to demonstrate efficacy. And you can see out 15 years now, our HIV positive and negative patients have very, very comparable outcomes. I only show this slide because in 2014, the drugs to treat hepatitis C, the direct-acting agents, became available. And that has changed the face of liver transplantation. And especially in our co-infected patients, you can see that that blue line is before 2014, we didn't have those drugs. and the 5-year survival rate dropped to about 50%, which is the level that our government says maybe you shouldn't be doing it. Last couple of slides here, I want to point out that the prophylaxis that we use is so important. You want to prophylax against PCP. Some people say indefinitely in the HIV patients. You want to prophylax against fungus for the first month. You want to prophylax against CMV for about 6 months, which is probably a little bit longer than you're doing in your kidney transplant recipients now. And we also use azithromycin for MAC, to prophylax against MAC if their CD4 counts drop below 75. I don't have it on this slide, and I apologize for that, but the other thing, in South Africa, where they're doing transplants between HIV positive donors, deceased donors, and HIV positive recipients, they prophylax against tuberculosis. And they prophylax against tuberculosis in the HIV positive recipients for a lifetime, because that has been a significant problem and is a bigger problem. Tuberculosis follows HIV and is a fairly significant problem here in Africa. But using that rigorous prophylaxis, we didn't see any progression of HIV to AIDS, and I won't get into the Kaposi sarcoma, but that's no longer a problem either, because there is a drug to prevent that. Now, the real problem in all our recipients with HIV is they don't do well on the waiting list. They can't afford the time it takes to get a kidney transplant or a liver transplant. So in 2014, actually, President Obama, the transplant community, again, rallied as a community to change the laws in the United States, because we were not permitted to use HIV positive tissue in HIV positive recipients. And that has decreased the waiting time. For example, if you're waiting for a kidney transplant from the deceased donors in the United States, you're waiting 7 or 8 years. If you can accept an HIV positive organ, and they're perfectly good organs as long as the donor doesn't have HIV nephropathy, and we make sure they don't, the results are the same. They only have to wait 6 months, less than 6 months to get an organ. And yeah, I just want to point out in this picture, I'm a little bit irreverent, and so people are asking me what President Obama was doing, looking around at me like I said something inappropriate. And what happened is he asked us if we were smiling when the photographer came in, and I asked him, should we be? And he said, turned around and he said, yes, this is the only bill that has passed all year. So great deal of support there. Now, I want to talk about that government support as we talk about transplantation in Tanzania, because the WHO has a resolution that was recently passed to increase the availability, access, and oversight of transplantation of human cells, tissues, and organs, and have a particular focus in Africa. And I think it's really important to be recognized as a member state, to get support, to increase the capacity in terms of technical expertise, the infrastructure for developing a deceased donor program, which is so complicated, and the equipment that's necessary for that. And I think Nima, this very cute girl, has brought us together. Dr. Syed had talked about fate. Well, it is fate, and I want to just highlight the fact that we are going to get her to transplant, or we're going to have every effort to get her to transplant. But I think we need to use her as a platform for establishing an ongoing collaboration, and really help Tanzania in any way that you think is appropriate to change that map. so to change the color of the number of transplants here, we have seen incredible programs here in Dodoma and at Benjamin and Kappa Hospital, and also in Dar es Salaam. And so 128 kidney transplants have been done. And I think it's so important to continue this collaboration, and look forward to working with you in any way we can. So thank you very much.
Thank you all to the presenters. Now may I get comment, question, reaction from Tatu? I'm very specific because this is at the Transplant Center at MOROGORO. Tatu, say anything. No, you ask first, and then I'll come.
I think the presenters, my name is Dr. Gabriel Tatu, I'm a general surgeon and gynecologist. We started way back in 2017 now. Now we have 91 patients done. We don't do spouse-related donation, as he said, but we have only like relative related. But then the operating time, Dr. Mashama said 7-8 hours. It's because you don't have enough team. If you are doing the donor and then shifting yourself to a recipient, so you expose your recipient at long operating time, which is the risk. 7-8 hours is a long. So as he said, and of course we have to really work together. Let's join hands. Thank you.
My dear.
Thank you very much to all presenters to a very interesting and challenging treatment. My first questions to Professor Mwashamba on the aspect of donor. How easy is it to get kidney from a donor? The challenges they encounter in terms of educating the community and the ready availability of donors. Secondly, may I just ask, isn't the tissue typing important these days? Maybe I need to be educated on that, because I'm seeing spouse donating kidney to husband, probably they don't have the same blood group or maybe tissue typing. The second question is to our second team of presenters. Currently in Tanzania, we are on the learning curve, and it has not yet created impact to our community. Now, with your experience, how easy is it funding, either from the insurance or from the government, in terms of sustaining the post-transplant patients? Because I saw it in South Africa, it was quite expensive, and most of the insurances were pulling out. So I don't know the experience in the US and the sustainability, because then this is a food for thought. Tanzania is having this new technology.
I think one of Mashaba's patients who got kidney from the wife, just married for that. It was a newly married wife. My colleagues.
I think as long the wife is a legal wife, we don't care about how long they have been married, I think. And it would be also very difficult to know whether the reason for marriage was for the kidney transplant or it was a mutual relationship that ended up nation. So maybe one of the things that the new legislature should look would probably, if we think people are marrying because they want kids from their spouses, then there could be a clause to maybe prohibit depending on the duration. But I think, again, that would be quite subjective because you can't tell why people are dated. There's no way you can quantify the nature of relationships. Okay, so should I proceed to answer the other questions?
Yeah, so that same question comes because this is a wife, and my dear and I knows that this person has to be genetically neglected. The wife is not genetically neglected, so are you typing them? So
we do tissue typing to all cases, and you have seen that almost 25 to 28 cases that were done in transplant were of high risk. One of the reasons in the stratification of immunological risk would be degree of mismatch. Okay, but I think nowadays with the nature of medications that we are getting, we might go to a point where it doesn't matter even your blood group. Okay, Japanese, for example, have good experience on transplants on cases where they have cases which are ABO compatible. So I think with the nature with current innovation, the newer sciences on medication, immunosuppressive that are coming, the prohibition of mismatch and prohibition of ABO incompatibility might be not a big problem. Okay, and I think that is true. But the other truth is up to 45, 50% of cases are usually O positive. So mismatch is not a big problem in terms of ABO incompatibility. Okay, and of course we have done all of them are ABO compatible. And Mutadunu talked about the duration. We used to, in the first case that we did, I think we did 8 hours when we were alone for the first time. And I think one would understand why that was so. But I think subsequently it is between 5 to 6. Okay, if you have multiple arteries, you have to be slow. That is, it doesn't matter how big your team is. You need to anastomose each artery separately and make sure that you save the nephrons. Okay, so I think one of the things that might increase duration of surgery would be the number of arteries that you need to take care of. Okay, and the issue of shifting, I think, is not a big deal because by we start the recipient half an hour after the donor has already started, and they usually. In some cases, the donor might finish earlier than the recipient, but most of the time we would finish at around the same time, so there's not much time wasted. Okay, and one of the issues that I think leads to that is that maybe urologists would require more training and experience with handling vessels. Okay, they would always, my colleagues would always say, now we have the vessels inside, now we have to come and assist. And each time we guide them to do that, maybe they won't be quite comfortable with vascular dissection. And especially, sometimes you may end up losing significant nephron if you're not careful with vascular dissection. Okay, so the issue of tissue typing, I think that was quite well addressed. I lead and I said, hey, I think we should work together. DMC, Uganda are coming to learn from us, and I think they should also feel comfortable when learning at MNH. Okay, and I think maybe in the next next KT, we are going to make sure that we invite our colleagues from MNH so that we kind of build a nation. construct a kidney, not kidney, organ donation center, kind of center of excellence. Okay, so I think with this kind of vision of working together, we may utilize that space a lot better. Okay.
Which our people they have. Thank you.
Thank you very much. I would like also to congratulate all the presenters. Personally, I was very happy and delighted to hear, especially about the kidney transplant and the liver transplant in the HIV positive patients. Now, my question is, we've recently heard about patients being transplanted with organs from animals. Could you please elaborate more on that, especially that was done in the USA? If it is practical, actually it could be a life-saving process and reduce the waiting list. Thank you.
One last from who? It has to be very burning. One last question as well.
Thank you. I just want to hear comments from a little bit from our local transplant surgeon and the external team about low resource settings, because now we have 2 transplant centers that are doing kidney transplant, and the policy of the Ministry of Health is to try and give specialized services in like all the zonal hospitals. So how to balance the low resource settings versus the expansion of the transplant services, considering that even these 2 centers are not fully utilized? Like, do we think it's time? It's already time to like expand these services to other countries, or should we explore the ways that we can effectively utilize the available 2 centers first before considering expansion? Thank you.
That's a nice question.
Thank you, Mr. Chair, for allowing me to ask about this question. My question goes to the entire group that are here, can be spearheaded by Mashambwa, Professor in BELIVE. There are several legal frameworks that are required to be met for you to establish a transplant service. And to my understanding, within the Republic of Tanzania, we do not have an enactment by the Parliament regarding policy or structure of doing kidney transplants, be it the only transplants procedures we are doing. Do we have a common pathway that we can take to shorten the process and navigate through, so that we can have probably a multi-organ transplant act that can help us to pave the way? And what is the role of TSA in spearheading that? Thank you.
So I know the act has been prepared. It has been prepared. I know that. So let's answer the academic questions now. Let's start.
So just talking about cost, I'll talk about cost. Cost and insurance is a problem in the United States, it's a problem here. And trying to come up with a equitable system is difficult. But understanding the costs of end-stage kidney disease and end-stage liver disease, and the cost to the individual, the cost to the family, and the cost to the medical costs is incredibly important, and important for Tanzania to quantify what it takes to take care of somebody with end-stage kidney disease or end-stage liver disease. Once that has been quantified in this local environment, will you then be able to offset whether the cost of immunosuppression or the cost of kidney transplant, which essentially has been done in many countries around the world and always comes out ahead. So whether the cost of immunosuppression medications is high or low, and whether the cost of surgery is high in liver or kidney transplant, generally speaking, it's more cost effective to do a transplant than to care for patients with end-stage kidney disease. The exact specifics of the local insurance, etc., I can't necessarily comment on. And then to Dr. Nash's question about does every single specific hospital need a kidney transplant service? I don't think so. I think the way that it should be, again, thought of is end-stage kidney disease treatments. And so the specialty treatments, such as dialysis provision, such as fistula provision, and complications of fistula, etc., possibly should be extended around the country. But until appropriate expertise has been dealt with and the local folks thinks it's appropriate, then the expansion of kidney transplant itself should be sort of carefully considered by the local experts before too many centers are opened up and the volume is low in all of the centers. So those are just a few of my thoughts.
I don't have much to add to that. The question about matching, and we have the same situation in the U.S. that the wives are giving to the husbands, but the husbands don't give to the wives. Not a bunch of babies, but I think the matching piece of it is pretty much gone away in the U.S. If you have a choice of doing a perfect match, then go for it. But if it's not a perfect match, if it's not a 6-antigen HLA match, for our deceased donors, the difference in outcome is marginal compared to the benefit of getting a transplant. So we don't, it doesn't, husband to wife, wife to husband, friends, most of our living donors are not related, but are just friends. And we even have altruistic donors that have, the other thing that we have is a paired exchange program. So if you have somebody who wants to give you a kidney and you're not compatible, we do swaps with other families. And that works really well. 30% of our living donor transplants now are from swaps, where the intended donor didn't work out. Yeah, it takes away the need, which you have a lot of experience with the team from Japan. They did a lot of ABO incompatible transplants. We didn't have a great deal of success with that, and so this is a much better option. In terms of the xenotransplants, I think it's a little early for the xenotransplants. I was surprised that they did they did a pig heart into a human and 2 kidneys now. The kidneys, both the patients didn't survive. They survived 2 months, one month and 2 months.
died of infectious complication because it takes quite a bit of immunosuppression. I think it'll get there, but it's not there yet. I think from an ethical point of view, I wonder who should get those kidneys. Probably people who don't have a chance to get any others. So that's all I have to say.
Is there any pending question on the target? We have question for them. Please.
So, from Mugisha on legal framework, what we have used so far is the hospital regulations and the hospital chapter. That is what we are using. But of course, as Akoko said, we are almost to the final ends to have a law enacted. Okay, there was an issue of maximizing the utilization of the two centers for kidney transplant. I think you will agree, and BMH has been doing visits to other hospitals where dialysis is done, dialysis are done, and we have actually done kidney transplant from patients from other hospitals. So I think such visits and the advocacy of the doctors who are attending these patients to educate them on where transplanting is possible, I think that is the way forward. But I think in this country, at least all those hospitals should be able to do kidney transplant because we have a lot of patients that will require services. And I don't think it is quite expensive. Uganda, for example, a lot of urologists, a lot of general surgeons. It just requires some infrastructure development a little bit, and then of course the channels on medications and training. I think that will be sufficient. So maybe some of the different hospitals should be able to do that, including the private one like other. Okay, and I agree with Peter that transplantation is yet to come. Okay, prohibitive costs are quite prohibitive, but one of the things that makes transplant costful is medications. Okay, Vasiliximab, Rituximab, the two almost halves the total cost of transplant in Tanzania. So I think with better supplies and availability of these medications, the transplant will be around 20 million, or if not less. So that too may increase the number of transplants. Education, yes, and advocacy, I agree. We haven't done good advocacy, okay, and especially in reaching out to donors, but we do that to families that have reported cases. So, the median fee is a good idea, but one of the things I've noted in this country is that doctors are very, very shy.
Just to wrap our good session, I think I said that we need to cost our programs. We need to look at what's the benefit of dialysis if you're going to keep patients on dialysis for 2 years. Because I think that cost magnitude is high. Which one is higher? And we might be surprised that NHIF and insurance might be convinced to transplant because they'll be spending less compared to if they continue with their life. It's because we don't know. And remember, a transplanted patient is a customer lost to the dialysis clinics. So many patients, if you walk through the clinics, you don't really agree with me, even at NNH. Nobody ever told them about transplant. Because people just want them to get coming with money. So
how is it to get the donors?
If patient knows they need transplant, they will find family and bring them as donors. Until this point in time, with no law, there is no altruistic donor because you never know whether they have been bought. So now you depend on family donations. Until that time, then you will have altruistic donors who will just be walking in and saying, I'm willing to donate to anybody who needs the kidney. Yes.
That also depends on how significant such a person is to the family.
Yeah.
If you are significant, you might get a donor quite early. Okay? Of course, we encourage that it is completely willful. But if you are less significant, you might get a donor for years. And the person who is known.
Of course, we have also seen conflicts from those same family donations, because as voluntary as it is, but there is a cohesion aspect within the family. You are the only person who matched your brother. How are you infusing this brother? And everybody is looking at you like you want your brother to die. And the brother will say, okay, we'll take care of you, your everything, your care, your food. And after 3 months, CKD gone, you start withdrawing substances you promised slowly. And the kidney needs to go back to the donor. Yeah. So all these are challenges. And I think it's important to start engaging kids from school, talk to them about transplant and the significance of transplant, talk to teachers, talk to important people in the community. I was waiting for Stock to say that the shares in Iran had actually helped promote donation, because they then saw it as something, a blessing. And so we need to reach out to important people in the community. You might not go, but you might go to the pastors, to the sheikhs, and talk to them, and they will talk to people in one service, in one weekend. Everybody who goes to any house of worship will get something about transplant. So they'll still be with us for today and tomorrow. We might have round tables during lunch and continue the discussion around transplant. And my own opinion would be to strengthen 1 or 2 transplant centers before we roll out. I know there are 3, because there's MNH in Baga, there's MNH in Makazila, 2 different teams, and then there's Benjamin Kapa. And all these are very low volume centers. That's why we are not picking up skills. So my own wish should be to have a center doing 100 cases a year before you enroll the next center and bring the whole team trained together, so that they don't go and start the same learning curve you went through when you work together. That would be ideal. That's how we build Orthopedic Institute grew up to be an important institute. It is today. And that's how Jakaya Kikwete has managed to grow. The problem is, when you grow alone, you start creating monopoly. You will start hearing MNH saying, hey, Uganda, give us that center, we'll run it for you. They don't want to help you when they have attained the right volume. And Benjamin Kappa will say, hey, KCMC, give us your transplant units, we'll run it for you. It was some money, yes. So otherwise, thank you so much for all those that contributed to this session. And may I welcome the floor manager to tell us where we are going for our lunch. You want me to shout or you are coming?
Lunchtime, ground floor.
Same place.
Same place, we'll be back here at 4 o'clock on dot.
Okay, let's go for lunch.
We achieved within 2 years of this phase 2, we managed to perform about more than 300 laparoscopic procedures. And now at our department, this basic procedure is now becoming a routine. So whenever you have appendicitis, cholecystitis, cholelithiasis, so these ones are now routine. And you compare it to the other phase, now the number of surgeons who are able to perform this one is increasing, because at the time when we were inaugurating, only we were like 2 or 3 surgeons who could perform, but now the number has rose to like 7 surgeons who can perform this procedure. So apart from this, let's take a look at one of the basic procedure, which is laparoscopic procedure. Let's get a picture of it. Since the inauguration of this laparoscopic procedure, we managed to, within this period of 2 years, we managed to perform 125 procedures. And during this time, 15 it was a conversion to open, and we got complications of mostly which biliary injuries, but thanks that all of these ones were collected and the patients are all doing fine. So you can see at this time this number is really interesting, because for within a period of 2 years, then you perform all this number, it is quite encouraging. So you can see I was performing, this was a diagnostic laparoscopic procedure. So there's the one you see behind where guide team that I was showing them how to perform. So it was like on job training. Let's go to the advanced GI laparoscopic procedure. This one is actually a new service at our center, because we have never done that before, and now it's time that we are starting to introduce the advanced laparoscopic procedures. Now, we can say that we have made a profound progress since the inauguration of this. We have managed, within a period of 2 years, we have managed to perform 31 advanced laparoscopic procedures. To mention the few that we have done, one is laparoscopic hair with fabrication. Also, we are doing laparoscopic fabrication with an orthoped. We have managed to perform hepatic cystectomies. Also, we have managed to perform laparoscopic transabdominal, retromuscular, repairs of gastric hernias, and tabs and tapes. These ones are advanced, but they are now, thank God, they are now becoming common to our department. And within this year, we have managed to perform the 2 advanced ones. The one is this laparoscopic assisted light hemicolectomies, and we also managed to perform mesh lectopixis. And the one that we did last month, which was a historical one, for us we call it as a historical success, we managed to perform laparoscopic abdominal perineal section. The good thing about all these advanced procedures, this GI laparoscopic, is that we managed to do them, though there are some challenges we'll talk about, but we successfully managed to do them with no complication. That's the thing that we are proud of. So why was this possible? There are a lot of things that we could talk long throughout the day, but for our case, we believe these 3 are very important factors that helped us to perform. We have a very dedicated team of surgeons and nurses who we work together. Before a procedure, we sit together, we discuss. So a dedicated team of surgeons is one of the things that has helped us to move to this point. The other thing is capacity building, that we have been having this tendency of having collaborators. We have collaborators from Calgary University, Canada. Also, at one point in time, we invited Dr. Ligo from Wimbili. We worked together. So from there, we've been having all kind of collaborator capacity building. So this one, through this capacity building, we have managed a lot to move forward. And the one thing that I cannot forget to mention is management support. The hospital management has been very, very supportive to this extent, so we cannot put them aside with all this success. So you can see the one in the middle is Dr. Yuni from the University of Calgary. So we were doing one of the laparoscopic procedure at Uganda. So we've been having this regular visit from mentors from Canada. So we're working together. So what are the challenges? Challenges, I guess, are very common, but I highlight some which are very critical to us, and then they are hindering us for. So one of the challenges that we are facing is shortage of key surgical services and consumables. During the inauguration of this event, Professor Kokos highlighted about it, the issue of number one, the issue of energy sources. Actually, you cannot perform very well this advanced laparoscopic procedure if you are not sure you are not having a very stable and advanced technology energy sources like harmonic scalpels, like silications. So we are missing this. So we see how do we deal with that problem. We are also missing NLGI staplers, VLOG switches, and some of the very important bond retractors and the other important working devices and consumables. But despite missing those, we have devised a mechanism to deal with it. And the other thing is learning curve. You know, when you start, you cannot start learning. You have to start crawling and then you go to the store. This has led us to some of the procedures to take longer time. But we are doing it successfully, but it has led us to take some of the procedures take a long time. The issue that we cannot neglect is the awareness of this such kind of procedure in the public is still very low. So this one is a very big challenge because you meet a patient, you see this patient can benefit from one of the advanced procedures, but you tell them, you start narrating, they don't know anything about it. The thing that also we cannot forget to speak about is issue of cost index. These procedures are very expensive. Accessories themselves need a lot of money because you find yourself, if you want to do, let's say you want to do the sleeve laparoscopic sleeve gastrectomy, you will have to need like minimum of three linear staplers. So, and one of the cost roughly, one of it might take like 400K in Tanzania. So for staplers only, you need 1.2 million Tanzanian shillings for staplers only. So you have not yet put aside the other cost of learning this procedure. So you find yourself, the procedure itself will be simple. It may take like 1.8 Tanzanian million shillings just for the accessories. So you cannot. So if you put that into account, you want for the patient to pay, you find yourself that most of them cannot afford to undergo these procedures. The other issue, which is very common, is insurance issues. You find most of the procedures that can be performed are not in the list of the laparoscopic procedures that are recognized in the NHIF and the other insurance schemes. So those insurance holders, they find themselves finding in the disadvantaged side. So other issue is the issue related to storage and the equipment, carelessness of some of the staff to the laparoscopic equipment. So you find you store this laparoscopic tower in one of the room. The next other morning you don't find one of the cables not allowed. Then next other time you go there, you find some of the equipment have been misplaced to other places. So you cannot undermine this one because it has a lot of repercussion in the future. So how do we deal with those problems? Is we usually do improvisation. So we improvise. For instance, we don't have this harmonic scalpel. What do we do? Luckily enough, we have this bipolar. But so at the time when if the patient is small, you use the bipolar. Then if it's not that much, it not help. Luckily we have the titanium steel clips. You apply them. If that doesn't help a lot, you go further. You use the intercorporeal suturing. So we do that. So we have to improvise depending on the circumstances. So staplers and VLOG, we don't have. So we are forced ourselves to do the lap assisted. You do the dissection laparoscopically. By the time you want to do the anastomosis, you have to do the main lap, the open up, maybe through phalanstio or through the SOMI or balabala, then you do anastomosis extracorporeal. But all this could be done laparoscopically. So through the sensation that I said, there is a challenge. We have devised a mechanism of doing these surgical caps. Last May we had the colorectal surgical camp, which is mainly we focus on the application of these minimal invasive surgical camps. And the other thing is media. We have devised a way that we go to Star TV. We talk about laparoscopic procedures and capacity building. We want as many as possible to get doing these procedures and to get specialization in that. So at Bugando, we have 2 surgeons who have went abroad for fellowships. So we expect when they come, we'll have a very, very big, one of them is in South Africa, the other one is in India. So when they come back, we have a very good team with good competence. So, as I said, we are lacking some of them. So what have we done? These guys from other collaborators, when they pay us a visit, we actually ask for donation. So luckily enough, last month we received 4 GIS staplers with lilots, and we got V-lock sutures. So these V-lock sutures, at the time, you might not know the importance of it, but one V-lock suture can save a lot of time with a lot of intercorporeal suturing. So we thank God this now is working, but we cannot continue with this one depending on donation until when. So we'll see what to do. So the other thing is the establishment of manuals to deal with those who are careless with the laparoscopic equipment. The last one is to solidify, to start new collaborations every now and then. So you see, this was me doing I trained in China. So during my residence, I was lucky enough that one of the courses you have to do you have to go through basic robotic and both. So this was one of the sessions. So what is the future in our hospital? The target, we want to widen the scope of doing advanced laparoscopic GI laparoscopic procedures. So we want at times that you hear Uganda, they do laparoscopic whipple, you see that it is normal. They do laparoscopic hepatectomies and hepatic biliary surgeries, you find that it is normal. Bariatric surgeries, laparoscopic cystectomies, and so many others. We want at time that it reaches a point that becomes a routine in our hospital. So we also have a target to raise the number of laparoscopic procedures that are being done. You take a ratio of open procedure versus the laparoscopic procedure. We want at least the number to get 30% within a period of 2 years. So the other approach that we think we want to do, we have in the plan is adoption of advanced laparoscopic procedure in emergency settings. Because we want at the time you go in, you suspect the patient is having gastric perforation. You go in, you intervene laparoscopically. We want that at that time. If you find maybe someone is having, so we want this thing to be done at our center. And the last thing that we also have started doing it through incorporation of residents is the creation of the world-class training center for advanced laparoscopic procedure. That's the vision we usually have. That being said, thank you so much.
Thank you very much, Dr. Kanan, for the updates on what is happening at Uganda. I think excellent work. We see the plans available as he presented, but we have seen the challenges, and one of which I see is the advocacy. People knowing that these services are available. I think this is one advantage of this meeting is the advocacy. We need to let people know that instead of being open cholecystectomy, then you can go for laparoscopic cholecystectomy. Without wasting much time, I'm now inviting Dr. Kitua, who will be presenting the experience at Muhimbili on laparoscopic surgery. And finally, we shall have some discussion. Minimum of
Maximum of 10 minutes, Dr.
Thank you for this opportunity. Good evening. So my name is Daniel Kitua, as introduced earlier. I'm a surgical gastroenterology trainee at Muhimbili, and I'll be taking you through the milestones and trends of laparoscopic surgery at Muhimbili University and its twin institution, Muhimbili National Hospital, which is the primary training hospital for Muhimbili University. So laparoscopic surgery was introduced in 2012, which was largely driven by collaborators from the Society of American Gastroenterology and Endoscopic Surgeons. And initially, the initial surgeries that were performed were the basic laparoscopic surgeries, mostly laparoscopic cholecystectomies. And 2 surgeons were initially trained in 2012. So over the years, we have had 18 formally trained surgeons who are trained under the MSc program from MOHAS, who can proficiently perform these laparoscopic procedures. So the current capacity of the institution currently is performing an average of around 25 cases monthly. So the trends of laparoscopic surgery over the past 12 years since its inception are projected. As you can see, we have had a gradual increase in the number of cases over the years. However, we had a slight decline from 2018 through 2021, and this might be implicated by the COVID-19 epidemic. The most commonly performed procedures at Muhimbili are laparoscopic cholecystectomy, diagnostic laparoscopies, lectomy, halasmyotomy for lubrication, and hiatohemia repairs. So over the years, we have had expansion of our services to the Muhimbili National Hospital Tanzanian campus, where laparoscopic surgery is also performed, and the introduction of advanced procedures that are currently performed in our settings include the laparoscopic and laparoscopic assisted colectomies, halasmyotomy for lubrication, hiatohemia repairs, splenectomy, abdominal perineal resection, and sleeve gastrectomies. So this has been possible because of training and capacity building, which includes the establishment of the MSc Surgical Gastroenterology program at MOHAS that started in 2012, the same year that laparoscopic surgery was introduced in our facility. We also have international trainings where the local surgeons travel abroad to have laparoscopic training. We have collaborators from different hospitals and institutions. And also in 2022, we had introduction of a laparoscopic simulation lab, a wet and dry lab at Muhimbili University, where since November 2022 we have had 66 registered trainees. Of these, 27 have successfully graduated the advanced laparoscopic training. And among these, 3 are foreigners from Uganda and Kenya. The challenges, I won't spend too much time on the challenges because the challenges are more or less similar to those that are outlined by our colleagues from Uganda. And this includes equipment shortage, which has already been mentioned, cost implication of these procedures, most of which are not covered by the insurance, awareness of the minimal invasive procedures, the learning curve, the lack of laparoscopic surgical sections in most parts of the countries. This is a major problem since most of the surgeons are trained, and once they have the capacity to perform the surgeries, they can't continue practicing because when they go to their local hospitals, they do not have facilities that can be used to perform these minimally invasive procedures. Also, we have a problem with lack of trained laparoscopic personnel, including nurses. Our fellows from Uganda are saying that one of the future prospects is introducing laparoscopic surgeries in emergency settings. So in our settings, the surgeons might be available to perform an emergency laparoscopic surgery. However, we will have limited number of nurses that are trained in laparoscopic surgery. Therefore, most emergency cases that would have benefited from laparoscopic surgeries have to be done through conventional open approaches. So the future prospect of minimally invasive surgery in our settings, expansion of the training program to the broad population of surgeons throughout the country, introduction of more advanced techniques as mentioned by our fellows from Uganda, improvement of quality of care, and increasing awareness. So in conclusion, we have seen that we have had a gradual adaptation of laparoscopic surgeries throughout the year, especially the advanced procedures, which are not frequently done. So we recommend more investment in minimal invasive surgery from stakeholders. However, more research has to be done on the technical, economic, and logistic feasibility of introducing widespread minimally invasive surgeries in our localities. Thank you.
Thank you very much, Dr. Kitua, for the highlights on the experience of laparoscopic surgery at the National Hospital. And now, I think one challenge that you did not highlight is on the commitment from the administrators, especially in public institutions. When you are like executive director of the hospital in public institution, you have a lot of competing interest. And therefore, when you as a surgeon, you are going to demand, can you provide me with, say, clips so that I can perform laparoscopic procedure, then he or she doesn't really pay enough attention, as this is quite an important procedure. For instance, at BELIVE, when we began, we had clips, which makes laparoscopic cholecystectomy relatively simple and quick. When we went out of the clips, which were from donation, then we demanded that can the hospital now provide the clips so that we can continue performing the procedure. As I'm saying now, it is almost 10 years. We never have clips. Then we had to invent other mechanisms of performing the same procedure by now doing it in a difficult way by applying the intercorporeal suture. Anyway, it becomes advantageous because people gain the skill out of it, but the procedure is taking a little bit more longer than it would if the clips. This is just a simple example. Let alone the demand for the high-end devices, where now we can advance into more advanced procedures. They are expensive and, as I said, a lot of competing interest. For the interest of time, a mention of pediatric laparoscopic surgery. I see Dr. Giloy and Zaitun are looking at me. We did not put them here, but also we have pediatric laparoscopic surgeries, quite a number, which is being performed at the National Hospital. This was only for adults. Having said that, should I now go to Dr. Kondo from KSMC? If Dr. Kondo, what is happening to KSMC and how do we move from here? If you can share your experience from KSMC.
Good afternoon. Thank you so much, one, for this particular topic. Great interest in our country. As for many years, most of the surgical procedures
as for many years, as we know, most of the procedures have been done on conventional open surgeries. Of recently, so KSMC, as part of the facilities in this country, started laparoscopic surgery way back in 2004. Probably is one of the facilities in this country to have introduced laparoscopic surgery in this country. Why did we embark on it? It's because KSMC has it's a faith-based hospital that serves most of the population in the zone. And our hospital has not been expanded too much with the population, which is rapidly growing. And outside the service, our surgical wards have been actually been so much congested. The procedures which were carried out as open, they had to spend more time in the hospital. Some of them were taking 5 to 7 days. The cycle side infection rates were also high, nearly 35%. So the way forward to sort out this problem, then we started thinking as some surgical procedures can be carried out laparoscopically. Thankfully enough that one of our local surgeons had an exposure to US for the training. But unfortunately, by the time when he came back, he had no team to work with, and nobody knew about laparoscopic surgery. So he was handicapped and he couldn't even a single procedure. So we had a team also coming from the UK, from Zambia, which they were collaborating with other departments, and we had the advantage of having them to introduce the subject of. They agreed. We started in 2004. So they used to come annually to KSMC. And when they left, we were also unable to proceed because we were scared to start laparoscopic surgery of those kids. So it took us almost 3 years not to do laparoscopic surgery on our own. We had to wait for the team to do it. But seeing this challenge, we had to sit down and think on the continuous training of the local surgeons. So what we did was to establish a telesurgery with interview link. It's a video, audio link that was between KSMC and Exam Hospital in the UK. So every Tuesday in the morning, we had to list down cases for laparoscopic surgery. And then our training from UK were mentoring us to go about doing the procedure. So we did that for nearly 4 years. And that helped us to build our skills, and somehow we improved through such a learning path. As we are saying, KSMC has been able to operate more than 2,000 cases of laparoscopic surgery, which encompasses the basic laparoscopic cholecystectomies, diagnostics, and laparoscopic areas. As recently, we have expanded to colectomies and APR procedures through one of our colleagues who has come back from training. So far, we have also managed to train other surgeons from other facilities within the country, and others from outside KSMC, including surgeons from Malawi and Zambia to have training. And our achievements so far the operating time has been so much reduced. I remember the first case that we did on our own, we had to spend 10 solid hours to operate the patient. And luckily enough, the procedure went well. The patient stayed in the hospital for 2 days and discharged. And you can imagine now as we operate the same procedures for 45 to 1 hour. So that is a great achievement for us to see that the operating time has been so shortened. But we are also have reduced the hospital stay for laparoscopic patients. Currently, most of the procedures are done as day care. Come in the morning, operated, and then discharged. And we, through this experience, we had to share with other surgical platforms from within and outside. So we presented our statistics to one of the forums in UK, which was sponsored by British Medical Journal in 2014. And we are lucky that our project was awarded the Karim Surgical Award in 2014. So that is what we have achieved so far, and we look forward to expand the spectrum of the surgical procedure that we can carry out to the export. Thank you.
Dr. Kondo, thank you very much for sharing your experience. And it seems like we have a huge volume. 2,000 patients, that's a big number. Congratulations. We have the last one from Seniani, Arusha, Dr. Benson, are you here? Just to take 1 or 2 minutes to let us know what is happening. Dr. Benson, please. While we are listening from Dr. Benson, we shouldn't forget that introduction of our new service, it was presented this morning by Professor Apoko on the keynote speech, that it should consider the safety, affordability, availability, accessibility. I think when we are discussing that, we want to look at this. Are we considering all these?
Yeah, thank you. My name is Dr. Benson Limo. Actually, it's not Serial, it's Arusha Lutheran Medical Center, which is a Christian-based institution in Arusha. You know, the seniors have spoken so much, speaking part, because most of the things that they say actually looks like it cuts across most of the institutions that are performing these procedures. So I think Arusha Lutheran is one of the centers, well, the earliest centers to start doing laparoscopic procedures as early as 2002. So I stand to be corrected, but I think it's from 2002, and Dr. Gades Paul Kisanga. So procedure were being done there until surgical residence was initiated in 2015, around 15, where so with the training progress as such, So we, even I, Mugisha, we are trained through Dr. Sanga and other surgeons who were there at that time. Frankly speaking, currently, I should say for our part, is the procedures that we are doing are still the basic procedures, and actually the number is still going down with time. The same thing that they've been spoken, the challenges are the same. Instruments is the problem, instrument carrying. And the other issues again is it's expensive for patients who are paying cash. So we depend mostly on the corporate insurances, such as strategies in this other insurance. The local insurance is not really doing much per se, because it's running the cost. It doesn't really cover the cost of doing the procedures. So I should not say much. I probably should say our prognosis is still guided at the moment.
Thank you, Dr. Benson, for sharing your experience. And now, we are missing is the outcome. We need to know the outcome of the laparoscopic surgery in the country. But one opportunity that is available inside this room is at the very back, you can see there is a simulator, simulator. I think one of the excellent across the globe, if I'm not mistaken, Dr. Sharif will tell us. So Atimu has currently, through collaborating with UCSF, we are having such simulators, the extra modern simulators, and we have managed to train some of the residents and the attendings. And this one is available. We're looking forward, I'm sure Professor Koko is listening, we're looking forward on how to cut across the country, and such opportunities are available for everyone. Currently at MOASI, this kind of training is available, and I'm pretty sure it's making a lot of difference in terms of training and experience in laparoscopic surgery. Because the bottom line is training. We need people who are well trained and who can come up with a good outcome. Saying that, only 2 questions, burning question before we can close these sessions and go to the next sessions. Please, any question from anyone? Yes, you are welcome.
Okay, thank you very much. My name is Dr. Julius. I'm a general surgeon working in Arusha. Mine is not a question, but it's like a request. Because here we have, let's say, 2 kinds of surgeons. There are the surgeons who were graduated at the era of laparoscopic instruments. And there are those surgeons who were graduated at the time where there was no those services available. But still they have the wish, this is because there's a competition in the country and worldwide. So my request is, why should we start like fellowship to one of the centers which you presented here, where those surgeons who have interest and they have a ability to join, they can get some kind of training, a fellowship like with no examination and dissertations. So I think it can, can share it should be the opportunity for those surgeons who are already in practice and they don't have those skills of laparoscopics. Just like a request for the TSA, can think about that. Because now we know the training is through the formal training, university residence and other stuff.
Thank you. Dr. Julius don't want examination, neither dissertations. Okay. Yeah, so with that one, I think it's, as we expand the services, I'm sure at one point we shall be there, where the training, the attachment, the mentorship is available. Currently, we are still struggling. That's why I said we have such an opportunity. Even Dr. Julius, you can arrange and attend the training, and subsequently, I'm sure we'll get there. But certainly we shall be there.
in one time. Thank you.
Thank you very much. The kind of talk we are doing now is very, very important in the direction towards where we are supposed to be. The first world countries are moving away from the laparoscopic, they are going to robotics, and probably with a number of instruments that will come to us after they have no longer been of use in the high-end income countries. My wake-up call or my comment is, how are we using the opportunity of local hospitals to support another local hospitals? The way I've seen, Arusha Lutheran Medical Center started the first laparoscopic surgery in 2002 under the collaboration of the Denver, Colorado in the US. Kilimanjaro Christian Medical Center, where I was trained, they started laparoscopic surgeries around 2004 with a support from Northumbria in the UK. We have heard from Uganda a few years ago. They started a collaboration between Uganda and Canada. The most experiment also is vis-a-vis Tanzania and US experience. I'm not seeing very much of the collaborations between local teams, whereby MOHAS or Muhimbili can tap the experience of 2,000 cases that have been done at KCMC and build up the capacity by even having an exchange of students, residents, vis-a-vis those staff who are interested in laparoscopy. And I'm very much happy that I've seen KCMC Benjamin Mkapa collaboration, whereby a mentor from KCMC is mentoring colleagues from Benjamin Mkapa, which they are paving way between local institutions. What are the barriers that are affecting us to really reach out to the other institution and share the experiences? And my second comment is about how do we troubleshoot the problems biomedically on the instruments, be it lens, be it gas pipe. I understand there are times we have to walk from mechanics to mechanics in downtown Dodoma, fixing a mechanical, the oxygen the carbon dioxide insulator cable, and we walked until we improvised certain technique. And probably others are having such particular problems, and they have different ways of sorting it out. And looking at it, are we engaging the biomedical engineers in our facilities to sort out this so that we can have local solutions? Yes, we are suffering short of clips. We have Chuchuma and Ganga in Tanzania. We're having producing these iron bars. Can we engage the engineers also on board as we are thinking of innovation to use local expertise to create those particular instruments? Those were my comments and open for discussion throughout the meeting. Thank you.
Thank you. Thank you, Dr. Mukisha. The last one, biomedical engineers. Yes, actually these are very delicate equipments. Sometimes you see someone using camera and doing it in the way. We do engage biomedical engineers, and for the same, the MOHAS University now has established a degree program on biomedical engineering towards addressing the same as you are saying, that these are delicate equipments, very expensive. We need people who are trained to run these equipment. The second one is on how can we use the other sister institutions towards capacity building. I think the only area is deciding to do so. Otherwise, we have no any other reason not to do so. And the first one you said, the first world is running towards robotic surgery. We are now getting into laparoscopic surgery. Maybe Dr. Sharif, Dr. Stoke, and Dr. Lim will tell us laparoscopic surgery versus robotic, and where do you see us in that area? Okay. We shall also have the UK experience, the last one from Dr. Sharif, and then UK experience, we finish the topic.
surgery is cost. And so is robotic surgery better in certain situations? For sure, it's better for prostate cancer, robotic prostatectomy, APR, rectal dissection, low pelvic dissection, and for hepatectomy. But the rest of it, colon surgery, gallbladder surgery, the majority of general surgery, the need for robotics, or the benefit of robotics isn't necessarily something that we need to jump at straight away. Because industry has excelled or kind of spread robotics in America, general surgeons are using robotics. But really, when you look at the cost-benefit analysis and the real benefit for gallbladder surgery, for colon surgery, there's not a huge benefit. So, but for specific pelvic surgeries and possibly hepatic surgery, there is a significant benefit. So once you get to that stage of minimally invasive surgery for those specific urologic procedures, gynecologic procedures, hepatic procedures, then it would be the time to invest in robotics.
Thank you, Sharif. I think we heard Dr. Mukisha. Yeah, still we need laparoscopic surgery a lot. There are some specific indications for robotic. Maybe we can have experience from UK. You're welcome.
Habari za mchana. My name is Dr. Mark. Some of you have met me before. I think the things to say about the UK experience is laparoscopic surgery is universal. We perform it in every hospital. Everyone is trained in it now, and that's been a transition over the last 10 years. A comment about robotic surgery is there are plenty of people in the UK who would describe it as an advanced laparoscopic platform. There is a question as to whether in a country like Tanzania you could jump from open surgery to robotic surgery, and there may be some opportunities to do that, but my personal view is that you are beginning to get ahead of water in your laparoscopic surgery. I've seen some excellent laparoscopic surgery performed in Tanzania, and I think has been highlighted, it's probably around sharing experience. So in the UK, for example, a trainee would be considered trained in laparoscopic surgery, laparoscopic cholecystectomy, when they've done about 150 laparoscopic cholecystectomies. Pretty much all appendectomies are done laparoscopically now, as well as a host of other procedures. I'm a laparoscopic colorectal surgeon. I do all my major resections laparoscopically, unless there's a really good reason not to, and the outcomes are better. Sitting next to me is a gentleman who's probably got more experience in the room than anyone, probably over 10,000 laparoscopic procedures. He's going to hate me for saying that. He trained me, so I think you should hear from him. I think my only final comment will be that laparoscopic surgery is the sort of the pinnacle of surgical development in Tanzania, and it's absolutely right to be pushing that forward, but it's also really important not to forget about the lower end of surgical care in the country and the big disparities there are between what's available in some of the biggest centres and what's available in centres that are still performing a lot of basic surgery.
Thank you. Dr. Christian, also from the UK. I'll move away from robotics, and I think it's been eloquently summarised from our American colleagues, the role of robotic surgery in clinical practice. I bring you back to your experience here in Tanzania, and you've got the advantage of learning from the mistakes that other centres have made in the evolution of laparoscopic surgery So you take an example of cystectomy, the sudden surgeon's experience in the States and the high incidence of bile duct injury. And it all boils down to proper training, accreditation, and dissemination of knowledge. So I would look at the literature and learn from that. There is always a learning curve. You can shorten your learning curve with appropriate experience and accreditation. So in the UK, we have set accreditation standards, mentoring models, and that's something I would strongly endorse.
Thank you very much. I think just he concluded by bringing in the question of safety. Whenever you want to establish these services, make sure that the safety it takes the upper hand. It was just this afternoon I received a call. People were performing laparoscopic cholecystectomy and they had a bile duct injury and the kind of stuff. So I think safety should be the first thing before we can embark into this. By this one, it has been quite an interesting topic, but time is not in our side. I should ask you to give clap to the presenters. Thank you very much.
Thank you very much, Dr. Mwanga, for a very nice hosting on this remarkable session. So without wasting time, ladies and gentlemen, and I'll open up for the first session of the day, where we're going to have like 3 presentations. So it will be back to back. So I'm going to mention the presenters, so you will move forward for the sake of time. Dr. Charles Mungo, Dr. Muganizi, and Dr. Elkusum, the presenters. So our first presentation will be from Dr. Charles Mungo, who is going to take us through a case report on a huge paratesticular laparoscopy in a 20-year-old male, a case report in literature review. So Dr. Mungo, you are on. Is Dr. Mungo around? Okay, the informant tells me that maybe we start with our sponsors, Kusum, the representative, then we're going to get on with the Charles. Welcome.
Thank you. So, good evening, everyone. My name is Peter Gitao. I'm from Kusum, so I'll take the shortest time possible to give you a brief preview about the company. But before I go into talking about Kusum, I would like to appreciate all of you and to appreciate TSA for giving us this opportunity for partnership. And I'd also like to encourage all of you, once you get time during tea break, lunchtime or evening, to visit the booths out there. We have many innovative products. We have partners who want to be always coming to these conferences year after year. And when you go down there to see them, you give them a word of encouragement to come back next year. So Kusum is a group of companies. We've been partnering with TSA for the last few years. We are headquartered in 2 countries, that is in Ukraine, Kiev, as well as in New Delhi, India, and we have manufacturing plants in both countries. So we have a global presence of over 40 countries running around Latin America, Middle East and Africa, CIS countries as well as the ASEAN countries. And to give you confidence on the use of our brands, we are accredited by all the regulatory bodies that we do trade in, including our local regulator, who is the TMDA. So if I go to the brands that I want to speak about, I would like to thank you for the support you've been giving Kusum on Serata, which is serratiopeptidase, a proteolytic enzyme with both anti-inflammatory and analgesic as well as tissue repair properties. So having a big importance in your post-surgical patient for faster wound healing. So we also have MOROGORO, which is methylcobalamin enhanced strength for peripheral neuropathy. But today I want to introduce to you about LMICS. LMICS is a lonoxicam. It belongs to the oxycam class with similar pharmacological profile to other oxycams, but it is 10 times more potent than piroxicam. And it was primarily developed to reduce the unwanted side effects seen with other NSAIDs, primarily the GI irritation. So, in the WHO 3-step analgesic ladder for pain management, LMICS occupies the step 2 and step 3 for moderate pain as well as severe pain. And Lonoxicam has scope in chronic pain, where we're talking about rheumatoid arthritis, osteoarthritis, as well as spondylitis, low back pain. In acute phase, in acute post-operative pain, following all kinds of surgeries, acute sciatica, injury pain. And why we need Lonoxicam is that, as I've said, it's 10 times more potent than piroxicam, and equally effective as diclofenac, given as a TID dose, but with few adverse events. So it is a superior alternative to opioids, morphine, and tramadol in relieving post-operative pain. And it's very effective in osteoarthritis, rheumatoid arthritis. It has a better tolerability profile than many NSAIDs, and therefore it's a better tolerated alternative or adjuvant to opioid analgesic for the management of moderate to severe pain. So we say we strike the balance between safety and effectiveness, where we have minimum inhibition of COX-1 and optimum inhibition of COX-2. And the dosage is you give 1 tablet for moderate pain, 2 tablets per day for severe pain. And the dose should not be exceeded 16 milligrams in a day. Then lastly, we've introduced muscle relaxant called Panache. Panache is thiocolchicoside, 0.25% topical cream for relief of muscle spasms. So it is used in the treatment of back pain, pain and contraction of the neck, shoulder and upper limbs, stubborn, stiff neck, myofascial pain syndrome, post-traumatic pain syndromes, as well as an adjuvant to treatment of painful muscle contractures in spinal pathologies in adults and adolescents from 16 years onwards. So why we need Panache cream is that it reduces the pill burden. It's the first time in Tanzania we're introducing a topical muscle relaxant. No side effects like gastritis, hyperacidity associated with analgesic tablets. And it has a special technology where it is non-greasy and it has good spreadability, unlike other topical ointments. So we say it makes life easy in pain and spasm. And for shoulder pain, neck pain, lower back muscle spasms, we have Panache. That's the presentation of Panache. You apply a quantity that according to the size of the area, and you rub gently on the affected area 2 to 3 times. So for most acute cases, you use it for 7 to 10 days, but the treatment duration is usually determined by the physician. So it is not recommended to use in children under 16 years. So thank you very much. That's all from Kusum. Thank you for this opportunity.
Thank you so much, Representative from Kusum, for a very brilliant presentation. So, ladies and gentlemen, we are now open up for questions, because unfortunately the 2 presenters are not around, so that they are going to be given slots maybe tomorrow. So if there are any questions directly to Kusum representative before we open up to the next session. So I think the presentation was well understood. Thank you so much again, Kusum, for being a good sponsored partner to this important big event in our country. So much. Thank you. So I'd like to hand over back to the Secretary of TSA for proceedings.
So we are switching directly to AGM.